summit. Very elated to see you all in the second summit here. Today here we will be seeing convergence of policymakers, healthcare leaders, pharma bigwigs, industry captains, and medipreneurs, leading doctors, scientists and medical experts, and various stakeholders in health ecosystem from across the country and globe into one single platform. Today's summit will unfold three important components. One would be the conference, awards, and the expo. Before we begin and move into the main part, I would like to tell you all that we are live on two platforms. One is on YouTube, indiGlobal TV, also on FB, on Facebook page, which is indiGlobal Media Network. So request everyone who are having a phone to please, subscribe, share, and even, like those pages for us. Beginning with, I would like to now call upon our esteemed CEO and Editor-in-Chief, indiGlobal Media Network, Mr. Sudhir Gautam, onto the stage, please. And a huge applauses for beginning this summit on a positive note.
Thank you very much, Prerna. A very warm welcome to the esteemed guests, speakers, delegates from across the country who have joined us. The way they said Kashmir se Kanyakumari tak, we have speaker from Jammu and Kashmir and also from Kerala, which is also, and in addition to that, we have our esteemed key speakers and delegates who have joined us from Punjab and also Karnataka, Delhi, and many other states. It's going to be an amazing health summit throughout the day, and the idea of hosting this second indiGlobal Healthcare Summit, as we have all experienced and also had personal experiences during the COVID time, and the kind of challenges we faced, even the government, be it the state government or the central government, faced a scenario where they were unprepared. However, India stood up and rose up to this challenge and also stood as a global leader, be it vaccination, providing vaccine to others. In addition to that, the kind of best practices, innovation, the role of technology. Every state is known for certain practices and they are doing well in certain parameters. So the reason why we have the speakers from different states is they would be joining for the panel discussion and presentations, where they will be sharing their innovations and best practices in this second indiGlobal Healthcare Summit. It will be a knowledge exchange. And we would also be coming out with a summit report of the talks from these esteemed experts who are heading several organizations in the central government, in the global organizations like World Bank, and also several state governments. And without further ado, I would be calling upon our esteemed guest to mark the inauguration by lighting of the lamp. The actual inauguration will be by the arrival of the chief guest, the Honorable Health Minister, Health and Finance Minister with the Government of Telangana, Shri T. Harish Rao. He would be joining us at around 2 p.m. However, we would be starting off with pre-inaugural panel discussions. And for this, I would like to call upon our esteemed guest to mark the beginning of this second indiGlobal Healthcare Summit. From the Government of India, we have a representative, Dr. Anuradha Medoji Madam. She is the Senior Regional Director, Telangana and Andhra Pradesh for Ministry of Health, Family Welfare, Government of India. A huge round of applause for our guests to please join us on the dais, ma'am. I would also like to call upon Dr. Nagari Birappa, who is the Director for Nizam Institute of Medical Science, Hyderabad. Please join us on the dais, sir. I would also like to call upon our esteemed guest who has been part of several state governments. She has headed Suvarna Arogya Suraksha Trust with the government of Karnataka. And she has also been part of National Health Authority. And she is the advisor for several states. Now she is a public health specialist and a health economist and also a health system transformation specialist. Please join me in welcoming Dr. Sudha Chandrasekhar. A round of applause. I would also like to call upon our special guests who have joined all the way from Jammu and Kashmir, one of the key integral part of our country, India. Please join me in welcoming Dr. Shafqat Amjad Khan, who is the Additional Mission Director for Ayushman Bharat Digital Mission. Also join me in welcoming our special guest who has joined from the northeastern side of our country, Assam, which is considered the gateway of all the northeastern states. Please join me in welcoming Ms. Indrani Laskar. She is the Joint Secretary for Health, Family Welfare, Medical Department, Government of Assam. A round of applause for our guest from Assam. I would also Okay, now I would like to call upon Prerna to over to you.
Indrani Laskar, Joint Secretary, Health and Family Welfare Department, Government of Assam. Can I request Dr. Shafqat Khan, Additional Mission Director, AV Digital Health Mission, Jammu and Kashmir, to please come forward. Then I would request Dr. Nagari Birappa, Director, Nizam Institute of Medical Sciences, Hyderabad, to please come forward. Can we hear a few applause for our guests here, please? Can I please request Dr. Bijoy to please come onto the dais to join us for the inauguration and for the who's representing Kerala for us. Can I request all the guests to please come forward so that we can proceed with lighting of the lamp?
सूर्यकोटिसमप्रभा निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा वक्रतुण्डमहाकाय सूर्यकोटिसमप्रभा निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा वक्रतुण्डमहाकाय सूर्यकोटिसमप्रभा निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा वक्रतुण्डमहाकाय सूर्यकोटिसमप्रभा निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा
Thank you to all our dear guests to help us inaugurate. I would request you all to please take your seats so that we can start with our pre-inaugural panel discussion. So now we are back and we begin with the main and the important component of our summit, that is the panel discussion. This cadre, private players to play a more important role, CSR can become more meaningful, how digital health can support public health in India and where we stand, creating future-ready health workforce challengers and facilitators, role of medical colleges in public health cadre and existing teaching faculty and training newly commissioned cadre. To have this panel discussion, may I call upon Dr. Nagari Birappa, Director, Nizam Institute of Medical Sciences, Hyderabad, which is one of the premier government institute of Telangana. Sir would be moderating the panel discussion for us. Can I hear a few applause for our moderator here, please? Further, I would like to call upon Dr. Anuradha Medoju, Senior Regional Director, Telangana and Andhra Pradesh, Ministry of Health and Family Welfare, Government of India. Further, I would like to call upon Dr. K.V. Ramana Reddy, Dean, Malareddy Dental College for Women, Hyderabad. We have us joining Shri Sharat Anand Jupali, Managing Director, Shiva Medisoft Services, Hyderabad. And we have Major Dr. Ashlesha Taure Kelkar, Consultant Digital Health, Maharashtra University of Medical Sciences, and she has come from all the way from Mumbai and who has already served the armed forces. Can we hear applauses for Dr. Ashlesha, please? And then finally, we have Dr. Ashutosh Biswas, Director, All India Institute of Medical Sciences, Bhubaneswar, Odisha, joining us virtually. So, can we have 2 mics, please? Cordless mics. Hello, Chair. So, Dr. Nagar, over to you. Thank you.
Good morning. Let me thank the indiGlobal Summit for giving me this opportunity. Basically, I'm a surgeon. I'm a surgical gastroenterologist. Became an administrator few months back. All these days, I spent in operation theater. Now I have come out of the shell and seeing public health. You can understand my knowledge about the public health. A man who has confined to the operation theater and now looking at a global, at a Telangana, how the public health system is, trying to learn, would like to put some challenges which are facing by the public health system in order to retain them, in order to maintain the public health system and to get the doctors in a public health system. It's not an easy task. Well, I made few slides trying to explain, as far as my knowledge goes, how difficult it is to maintain, to retain, and to build infrastructure in the public health systems like PHCs, district hospitals, and tertiary care center. I'm working for a tertiary care center, so I know the difficulties in tertiary care center, but let me also see how difficult it is to maintain public health system also. I'm sure the entire country, entire world was definitely looking very interestingly, anxiously, difficulties of the public health system, more so after COVID pandemic. There were programs, I'm not saying that there are no programs. There were many programs, national programs. However, after pandemic, things have changed. The hospitals which did not have an oxygen, now all the beds have oxygen pipelines. There were no specialists, but now, yes, we have a specialist. There were no super specialists, now we have a super specialist. There were no ventilators. You have seen how many patients dying of not having any ventilators, simple not having an oxygen. But the today's scenario, after 2 years, it's completely changed. There's a lot of awareness among the public, a lot of awareness among the governments. So it's now, I think, settling. That dust is settling. So we know the certain frameworks in public health. We know that the specialist cadres, these are the doctors who are done an MBBS, who have done a specialization. These are all specialist cadres. They may be a general surgeon, pediatrician, orthopedician, and other basic surgical groups, including physicians. The public health cadre, the working in PHCs and CHCs, block hospitals, they're all the basic MBBS guys, probably with some healthcare management, or those who are done a P&SM. And we have a health management cadre. I think this cadre is very important. The government institutions lack this kind of a cadre. However, the corporate system has health cadre management like, financier, HRs, or people who have done a Master of Health courses, and teaching cadre like medical colleges, faculty in medical colleges. So these are all, the framework of any hospitals, government. Essential core principles are public health care cadre, which consists of public health professionals. As I said, they may have any MBBS with P&SM. Health management cadre, these are the people who are, I think most of here are from this group. And specialists, as I said, they are orthopedicians, maybe medicine, maybe surgical specialty cadre, and teaching cadre as per the NMC guidelines. The career progression for each cadre, what I mean to say is, the person who has done MBBS should have a career opportunities so that they can work well in certain group of hospitals. The existing GDMOs with 3 years of experience, and they should also have master course in public health. The special pay for an extra qualification, yes, this is very important. A person after a few years might do an extra qualification. There have to be some incentive. There has to be some special incentive for those for an extra qualification. And specialists and super specialists join these to help the specialist grade. The desired principles, the incentive scheme, it's very, very important to motivate the public health courses so that, the continued education, it helps, it gives a lot of boost to the professionals so that they stick on to primary health care center or district health care center or tertiary health care centers. District Health Society helps definitely in convergence between public health and clinical function. This is very important. It's a government work. And method of recruitment, we need to definitely identify the number of posts and recruit as and when necessary. Initiate urgent time-bound actions is most important by the government or any other cadre. So way forward for the states is a stepwise implementation of the plan, mapping of the existing public health personnel, making structure based on IPHS norms in existing facilities, and so on, so on. So what are the challenges? Resource constraints. I am sure these are the problems any government will face. But now the government of Telangana has really changed the dynamics of the healthcare in state of Telangana. It's mainly because of our Honorable Chief Minister and our Honorable Health Minister, sir. They have really changed the dynamics of the healthcare system in Telangana state. The resources constraints have been cut down. So there were a lot of financial resources have been pumped in the infrastructure development and human resource management. Manpower shortages, yes, they are, but it's been planned to encourage, it's been planned to organize all this. Infrastructure deficits have been corrected. If not, one has to really look into all these kind of things. Coordination and collaboration with other organizations is most important. rural and urban division. So if you see, the urban hospitals might be very well equipped, whereas rural may not be equipped well. So it's the time now to upgrade all the rural hospitals so that there is no division between these two. Policy implementation and governance is also crucial role in establishing a robust structure in public health. I think this is, we have realized during COVID pandemic. So we need to upgrade all these things. Policy gaps, if there needs a lot of discussion, and bureaucratic hurdles needs to be tackled and so that there is a better coordination. Strengthening the governing structures is very important, and so we need to address these challenges, which requires multi-pronged approach involving adequate investment in healthcare, improving infrastructure, expanding the healthcare workforce, promoting interdisciplinary collaboration, enhancing training programs, and strengthening policy implementation and governance mechanisms. So inadequate infrastructure, as I said, in rural areas, this definitely includes healthcare facilities, diagnostic center. I am very sure that government of Telangana is doing extraordinary work in this creating an infrastructure all over the state. The funding, absolutely no issue with the funding, but if any government needs to fund for a resourcing constraint, I think this is the time. Health disparities, as I said, between a rural and urban needs to fill that gap, and referral system should be strengthened. Limited public health workforce, yes, there definitely need to be looked into, especially epidemiologists, public health managers, health educators. It's not the treatment, prevention is also very important. Health information system, all these things needs to be computerized so that even a person in a tertiary care center need to look at what's exactly happening at public health centers. The awareness is the most important, and behavioral changes. And specialist cadre challenges, yes, this is the biggest challenge. Retaining specialists in any hospital is the biggest challenge, including a super specialist. So we need to really look into this, incentivize so that people can stay in a public sector. Training and continuing education. One need to train. One need to undergo continuous medical education so that their knowledge is upgraded each and every time. So overburdened hospitals, yes, of late we've been seeing there's a lot of importance given for public hospitals, public health care, and that's the reason why there's a confidence build-up amongst the population, and they are reaching the government hospitals very much now. In fact, my hospital right now, I have 1,500 bedded. Now I have patients, 1508 patients. You can understand the workload in a tertiary care center. The hierarchical structure needs to be maintained. Yes, urban-rural disparity should be cut down. Private versus public sector imbalance. Yes, we have to have sometimes PPP and career incentives. As I said, brain drain. People are going after MBBS to other countries because of the better facilities for them. I think this is a very important. One needs to look into why our people are going to other countries and serving. So we need to create facilities, we need to create incentives, we need to create facilities for all of them so that they can stay in our country and then treat the poor patients. So some of the challenges to address: policy reforms, increased investment in healthcare infrastructure, targeted recruitment and training programs, enhanced intersectoral collaboration, and other measures needs to be taken. Thank you very much. And I request our panelists, so they can have few words and then go for a discussion. May I call upon Dr. K.V. Ramana Reddy Garu? He is also a surgeon, so they have a relation between surgeons. So I request Ramana Reddy Garu to say a few words.
Hello. Yeah. Good morning, one and all. As this is a disclaimer here, as Dr. Birappa said, I am also a maxillofacial surgeon. But being in the administration for a very long time, public health, I feel, plays a very important role. As surgeons, we are overwhelmed and we are very, passionate about delivering the services. But there's a limitation to amount of services which we can deliver at the tertiary care centers. So this message is basically for the most of these students who are here is the role of what public health can do. And we have typically seen during COVID, whether it is a vaccination or whatever, you have to be at the top of in the pyramid trying to deliver the appropriate health care. So three issues are what will affect any individual, what we are looking in a society. One is health, other is education, other is housing. So health is a very important priority. So this is the onus is on us to how we are delivering it, where it is affordable, accessible, and where we are providing accountable health services. So we have the onus is on us. And again, the message is a lot of students are actually looking at public health, at going abroad and pursuing this education. My message is, Indian problems are Indian problems. We don't want Western ideas or solutions for us. We actually have to devise and look into our problems and come up with our own solutions so that, what works for us. So this is an important area where we need to look into it. And after being for about 30 years in the profession, if I have to choose another profession, I would go back and do public health. That is the message which I have. Thank you very much. I will pass it on to mine.
Thank you. Hello. Thank you, sir. Can I ask Anuradha ma'am your views on change of face of public health?
So thank you so much. First, I would like to congratulate Global Health Summit, all the organizers, and asked us to participate here to exchange our ideas, what we are doing in the state of Andhra Pradesh, Telangana, with other states, with extreme the guests which they are here from Assam, Jammu and Kashmir. I'm so happy to be here. And today we are discussing about the challenges in the public health management. What are the challenges we are facing? Why we made it, this cadre to be implemented in our country? In 2000, we know very well, during the COVID, that's a new strain, a new virus. No one knows about it. We handled MERS corona and SARS coronavirus also before, but to India, it's a major challenge. But as per the government of India guidelines, the total country and all our states, we become one. We could able to manage the COVID in such a within 24 hours. We have implemented in the port of entry, because I'm taking care of Chief of Airport Health Organization in Hyderabad, Tirupati, Vijayawada. Within 24 hours, anyone who is coming from China, that time it was started in Wuhan city. So from the China and the other, the 2-3, Singapore, the only 2 countries were there. But we have stopped at that time. Public health system, we never know about such a crisis happens to us, but it's an emergency. All of us together, and then we worked. Here, not only the administration, not only the technical field, even the community participation also there. This has a major role. So we all together, even you know very well about the COVID, and almost everyone, we, without any force or anything, we voluntarily have come forward and then we got it vaccinated. So this motivation, it is from the public and the private sector and the community participation. So this is a successful story of our India, our country, as compared to the developed countries. You know very well, the mortality, it's not much in India as compared to the other countries. So this is the one, it's a strength of our country, we can do anything. So on this line only, for every diseases, not only during the emergency, for every disease, we are concentrating on the treatment mode. Always clinical management, clinical treatment. But the public health is the one. If the community awareness is there, we can prevent the disease. So with this agenda, and then in 2020, you know very well, and then this a management, how can it be public health cadre management? Is it possible public health means, is it possible only with a doctor only? Without a praja, without the society communication, can we take forward that whatever we put our projects, can we put and then can we force the society? So much ethics are there for that. The tribal people are there, hilly regions are there. So different people have a different cultures. Even according to that, we have to frame, we have to give an awareness to them. And then we have to do it how the public health awareness should come. This is the way. It's not only a doctors. Equally, we are all responsible. The COVID has taught us, everyone, from the politicians to the executives and public, everyone, we all participated together. So it's a successful program. So we wish all the national health programs in and emergencies also, along with. So we should have a unity. Maybe we are different expertises in different fields, but we all come together, we can bring it. So this cadre, when we say, yes, sir, as said, there are the challenges are there. Because the government of India has rolled out, and then at least by 2026 is the one to give it to the states, to roll it out by 2026. There are a lot of challenges, you know very well. To make one cadre, it's not an easy thing. Because the cadre itself, and then until now, and there is a, as sir said, there is a primary health care and secondary health care and the tertiary care. But now the fourth one, it is coming too. There are a lot of questions in our medical professionals. But this is the platform where we can take it. Even other people can read the public health. I mean, they can study the public health. What we need is public health institutions. Now, we know very well public health institutions means only few institutions are giving the public health the education, post-graduations, and as the MBBS doctors, they know about the community medicine, which is no one likes also. Because during the MBBS graduates, which is a relaxing posting means, it's a community medicine. Because they can go to the villages, they can relax, they can go in buses, and then they can come back. So that's the way, but that's not the importance they know that time. I'm not denying it, but when we are in the medicine, we will think that so community के जाना है, बस देखना है, आ रहा है. तो ये एक relaxing part की जैसा हो गया. लेकिन उसमें जो है जब public health में अभी मैंने काम कर रही हूँ, मुझे उसका जो importance है अभी पता चल रही. And the second one, administration. Yes, I do agree. The medical profession is such a profession which is a long duration profession. From intermediate onwards, you must be knowing, I don't want to name the institutions, रखता है 10+2 के बाद पढ़ो 18 घंटे पढ़ते हैं, उसके बाद MBBS का सीट मिलता है. उसके बाद it's not easy to pass the, because every textbook it must be this much, and then they have to read for 16 to 18 hours for every subject they have to read. They have to keep it in mind. So together, 15 subjects, when they pass it out, the 15 subjects, they'll have a medical graduation degree. They doesn't know the parents kahan par hai, teachers, बस student, guru और शिष्या का relationship है, और कुछ नहीं है. जो दुनिया के बारे में कुछ भी पता नहीं है. तो ऐसे ही हम लोग MBBS पढ़ते हैं. उसके बाद पोस्ट ग्रेजुएशन के लिए लड़ाई फिर शुरू, फिर बुक्स पकड़ो, 18 घंटे पढ़ते हैं. एंड देन उसके बाद स्पेशलिटी होते हैं. स्पेशलिटी के बाद again for the super speciality, you know very well, and how many seats are there. Like the extreme guest now sir said, as a surgical gastroenterologist, because they are more oriented on the technical side. How I can support to my public. How can I save the other life? This is the only the thing that is there in my mind, in their mind. But there are no administration. कैसे करना है, किसी को कैसे बोलना है, ये एडमिनिस्ट्रेटिव ट्रेनिंग तो है ही नहीं है. After coming to the job and learning the administrative skills. Sir, I think for this, we need from the graduation side, the people, we have to develop the medicos or the super specialty or the specialist doctors as a leadership and administration. What we need for the hour, we are technically expert because we don't have a communication skills. हम लोग पेशेंट के साथ तो बहुत अच्छा बात करते हैं, लेकिन कोलीग के साथ हम लोग उतना अच्छा नहीं बात कर सकते हैं because we think that it's a waste of talk. Because technically we think that because what I have to say to my patient, that much only will testing. And the second one, socially. When we are in the outside, पता नहीं क्या है, everyone enjoys. But do you see any doctor is enjoying in the public? No. They think that they are occupied. अरे मैंने ये करने थे, ये डांस करने से मुझे कोई मतलब someone catches on my on social media and then उसको कुछ करेगा, और कुछ मैंने कुछ पीना है and then that time also it is restricted because I have to teach. किसी को ड्रग एडिक्शन के लिए बात करना है तो मैंने कुछ नहीं कर सकती हूँ. This is the real problem the students are facing and the doctors are facing. So I think they are also human beings. They should express. We have to encourage the administration and the leadership qualities from the medical side only. We have to encourage. हमारा leadership कहाँ पर दिखते हैं पता है? जहाँ पर वो लोगों को injustice होता है, स्टाइफेंड कम मिलता है, तो उस टाइम हमारा लीडर्स बाहर आते हैं. Then after that we never see our leaders at all. So I think this is the right time to make an administrators as a leadership qualities to develop even in our medical field. That's a mandatory to us because ultimately the technical people can give and correct advice to the society and to the public, as in during the COVID, how we have done, even for the oxygen ventilators, and then whatever, even the guidelines, and then how the survey has to be created. So these are all important. So what we feel is now this system, integrated approach, holistic approach between the organization, there is no difference between the any cadre. We are all humans. So with this humanity, we have to work together. The challenges, yes, it will be there. The different cadres are there. So how, if I absorb into that cadre, in spite of that, because this is an integrated way of approach to the public health, it will be successful to our country and to our states. Already the states are doing the work. I hope by 2026 we are thinking, but before that only, all together, because community awareness, community participation, it can be done by the social mobilization, by the social volunteers. Number 2, NGO organizations. Number 3, and any of the other departments, the industrial development, or it may be the small scale industries. So all together, all the ministries together, all the people together, we can work, and then these are the challenges, yes, but we have to adopt our own ethics, and then depending on the local, what we need it, according to that we have to frame it. And I think by 2025, our Telangana is a Bangaru Telangana, so we will not take him in 2026. By 2023 or 24, definitely the roadmap can be formed. So thank you, sir, thank you.
Thank you, madam. You brought out very important points, how the medical students will struggle, to pass exams and to get a postgraduate seats and super specialty. It's really, very, very hardworking, and of late it's become more tougher to get any seats. Thank you very much, madam, for enlightening all those things. Thank you very much. Let us see what Dr. Biswas, from the Director of All India Institute of Medical Sciences, Bhubaneswar, Odisha, what he tells. Due to time constraints, he's online. He's online? Yeah. He can speak for 5 minutes. Dr. Biswas? Is he online? Okay. Then let's move on to another speaker, Sharath Anand Jupali garu, please.
Good morning, everyone. I will be talking about digitalization in healthcare. I represent a software company, so I'm more or less the technical part, I'll say. In healthcare, basically, there are 3 participants: one, the patient who takes the treatment; one, the doctors and nurses and all who give the treatment; third is the policymakers who drive the entire system. I feel how exactly now that in the COVID period we have seen teleconsultations coming in. Now in India, what we see for public health care from technology perspective is patients are too many, reach is not complete, and the care providers are limited. There are limited number of care providers, which government is of course taking care of increasing more and more. But India is a vast country, so where the digital health comes in is each patient can be treated via teleconsultations. We have seen ICU, tele-ICUs are there. We have seen tele-radiologies are there. So what happens, the travel time reduces, the response time increases, and the treatments can be done at the remote level itself, and the expertise can be done given centrally. Second part, the treatment part is inbound hospitals and outbound outside hospitals. Inside hospitals, how digitization, medication charts out of it, they can prompt the nurses ki by 12 o'clock, these are the medications supposed to be given to so-and-so patients. Same thing can be done for outpatients, where who are, I am at home, I know what medication to be taken, and the technology tells ki boss, this is the time you take this particular medicine. Even the compliance can be done. Policymakers, if the digital data is available in the system, policymakers can predict ki, oh, that outbreak is going to happen in so and so particular place. That particular thing is going to happen. They can move resources, they can move things over there. So digitalization can play a huge role. The way we are seeing ABDM coming, the way we are seeing National Digital Health Mission coming, we are dealing mostly with private hospitals, so all are getting compliant with milestone 1, milestone 2, milestone 3. Now where an Aadhaar number is generated for each patient, which is linked with the Aadhaar card. So slowly I am seeing next 4 or 5 years, entire health records will come into a central repository. We are visualizing as like we have RTO app, your vehicles, everything is in one particular app. The same you will be getting a healthcare data also, your reports, your things, and all the hospitals are going to be centralized is what exactly we are seeing there. Thank you, Doctor.
Thank you, sir. We at Nizam Institute of Medical Sciences has an HMI system, and all the reports are integrated, and we send the reports to the patient on WhatsApp. They need not to collect. So as I said rightly, digitalization is very important. At the end of the day, we get good statistics. We know how many patients had a cardiac problem, we know how many patients had a stroke, and accordingly, preventive measures can be taken up. So epidemiology is most important. If I want to know the state of cancer stomach in the state, yes, definitely we need to have a digitalization of the entire system. The government of Telangana is looking for a digitalization of all the hospitals in the state. Thank you, sir. Let's move on to another speaker, Madam Kelker, Taude Kelker. Madam, need your comments.
Namaskar. Good morning to all. Good morning to the panelists, respected. It has been an enriching, discussion and experience from everybody. I am in the practice of public health currently. I work in the Rural Health Training Center and tribal villages in Maharashtra. What is the role of these medical colleges when it comes to the cadre, public health cadre? And when we say that there are resources which are constrained, what do we really mean by that? What are the challenges first of all, and how do we really overcome on ground? First of all, of course, the medical colleges, to be a part of this public health system, is already being implemented from the government side. So medical colleges have an existing infrastructure, an existing set of teachers, trainers, particular modules, which can be utilized for the, not just for the cadre, but also, sir, when we are talking about the primary health center or sub-center or community health center, CHCs, we are not really talking about specialists or even MBBS doctors. Here, we run the show with the help of community health workers. Community health workers are ASHAs, Anganwadi workers. And these were, as we all know, these were the soldiers. I am a soldier, I have come from armed forces. These were the soldiers during COVID. It was not us, not exactly the doctors, because in fact doctors were not allowed in the community. The villagers were not letting them come inside from the hospitals. It was these people, it was those ASHAs, Anganwadi workers, and ANMs, auxiliary nurse midwives. These are the people who are actually working on ground. There is one more post. I don't know how many people know about this. This is a CHO, Community Health Officer, who need not be an MBBS, who can be from allied health sciences, who can be from nursing, and mans a sub-center. I am very proud to say that in India, rural healthcare delivery system is one of the strongest. One of the strongest healthcare delivery system. We do not find such system even in developed countries. But what is the challenge here? Like sir mentioned, yes, challenges are many. We are going to digital age. I am also working with digital. So we think that if we are in the rural, we don't want to talk about technology. If we are talking of technology, we are talking of cancers and super specialties. No. Digital health is one, but digital public health is what we are looking at. India is the most populous country today. Is that a blessing? Is that our problem? What is it? It is upon us to decide. The most populous country and one of the youngest country across the globe. It is our strength. India is the most populous country. We have the most critical of the resources, that is the manpower. Today, we have the manpower, the young minds. What is required is training them correctly. So, if I am coming from a rural background and I am looking at rural healthcare, it does not mean I leave aside the technology. Public health technology is where we are heading. Like sir mentioned, Aadhaar card. Few of us know about it. Some of us have it already. But in due course of time, I'm sure everyone will be having this. Everyone will be talking about this. This is one of our visions and we are working towards. The role when it comes to teaching faculty, this is where we are supposed to concentrate, not making super specialties, but training the community health workers, the nursing staff, because when it comes to telehealth or telemedicine in the rural, a super specialist, maybe a neurologist, will not go there and operate. But a nurse who identifies a stroke early and refers the patient to a hospital fastest with the help of infrastructure will be able to save that one person. At the same time, there has to be awareness. So, awareness in the community. And there the digital health will help, even in the rural. We have approximately 8.9% or more population which is tribal population. This much population which is available to us, which is part of us, unless this comes in mainstream, we are disabled. Apache hai. 104 million people. When we talk of India, it is numbers, sheer numbers. These are not burden. These are the strength of our country. This is the real strength of our country if trained, channelized in a proper way. For which, like Madam mentioned, there have to be institutions for training. And not just super specialty or apex institutes, but also training institutes for the lower rank of healthcare workers at every stage. At every stage. There is something that they say that, how do we really create a future-ready workforce, health workforce? What is future? What is ready? What is force? What is the future that we are looking at? Is it only digital? Is there any human interface? Is technology going to replace us, doctors? Many of us are really scared. General practitioners say, patient chat Google लेकर आ जाता है diagnosis. He will ask us, हमको ये वाला investigation करके दीजिए और ये वाला दवाई दे दीजिए. No, technology can never really replace a human interface. It can augment, it can assist. When we say of, future-ready workforce, it is everybody included, not just urban, not even only rural, which is 70% of our 60 to 70% of our population. Not only them, not just tribal, all together. Like how much diversity we have in our country, all of us going forward into future together, matching our steps. It has to be at one pace. It is not only the technology. Technology everywhere. Advanced countries have advanced technologies. We too have technology. What makes us cut above the rest? It is the ethics, governance, if that is being maintained and that again being taught. Ethics, governance, technology without ethics is a vice. It is a monster if not handled with governance, with care and ethically. And that is how the governance part, the management of public health has to be at the very basic of our training. The public health training, the community medicine or preventive social medicine that we talk about is changing. Last few years we have seen NMC has given so many beautiful changes to the medical, paramedical curricula. We adopt families in the villages. The students go to these families and interact. What are they doing? They're not using technology, they are creating human bonds. These human bonds will make them rooted, keep them rooted, and make them stronger. Technology can only assist, make it better. But at the basis of it is human to human relation. And that is how, as Indians, we all are together. It is the ethics and governance that we are talking about in digital health that will bring us all together. We are considered across the world. We are, as Indians, we are considered, law-abiding, good citizens, generally not going the wrong way. This kind of behavior is not just a perception. It comes from our roots. While we are going up and advancing and going to become the global power in few years, not forgetting our roots is the key to stay strong, to stay cohesive, to stay together as one. Like Madam mentioned, like Sir mentioned, we have diversities, we have various other problems, but being together, being one, and being right is our strength. I think when we put this kind of training, this grilling, in our young generation, upcoming generation of public health, and all the healthcare cadres, we can achieve what we are looking at, India as the global leader. Right, sir? Thank you.
Thank you, madam. You brought out very important points. One is the digitalization, complementing or accepting the IRs and tertiary care center people, and ethics. One important thing you brought out, ethics. That's very, very important things. More than digitalization, ethics is, I think one should really follow ethics. Thank you very much, madam. I think Dr. Biswas is waiting. Can you have an, is he available?
Sir, ma'am, you have touched upon the ethics. Ethics is the one, it's not only for the medical fraternity. What I feel, to whomever would like to come, our younger generation would like to come to the public health, the first they should have a humanity in their hearts. I want to serve to my society. I want to serve to my nation and to my world. So when that it comes to into their mind, even though they are in a different fields, it may be, it's not a doctor or the nurse has to do it. Everyone should have a humanity. Once that human touch and ethics are there, definitely the public health, because I'm living in the world of TB. Tomorrow I may get it, my mother may get it, or my child may get it. If we have that apprehension, definitely we will take all measures. So I think in all the professions, all the youngsters who are going to come into this cadre, so I request on this platform, you should have an empathy, you should have a humanity, you have a touch to the feelings. And then it's a prevention, because for the clinical management, yes, patient acha hua, theek nahi hua, there is something you can put a bar, but for the prevention there is no bar. And then your heart itself, and then it has to see. So I would like to add upon. Thank you.
Yeah, can I ask Dr. Viswas to speak on his views on changing face of public health?
Yes, sir. Good morning to all of you, sir.
Yeah, good morning. Can you go ahead? You can go ahead, please.
Respected chairperson and the other dignitaries on. I am extremely sorry and apology for not being there in person. It was some unavoidable situations in our institute. First of all, I'd like to thank the organizers, indiGlobal, for inviting me in this very special the second health care summit. So just all the speakers, I think, covered almost the important things that I'm going to just a few comments on the digital health, public health. What is the scope of digital in the public health and different institutions? Being the tertiary care hospital, the AIMS, here in Bhubaneswar, sir, what exactly were doing this? I will go for a quick, probably a overview on that. So, if you talk about the sector, health industry, now digitalization of the health system is a very important. The care services. That's the mission mode now the government of India has taken a digital health as a APTM, Ayushman Bharat, digital, which is covering the all in Java and this health active and that creates probably it is not only the patient but also the health care provider registry. So this is this is going to create a one platform. That is what we need. And the single digital platform is going to help, and that is how we are going to work. If the one hospital is the health record of the patient, that should be accessible to anyone in India. But because of this software, this program, health, the probably national health, the authority is now going to create all this in putting in one health everywhere so that everybody should, eh, the data should go. There are several issues are there. But, data safety and management. We take care of the national health authority. So, so digital of the about the health providing the services to the healthcare recipient, the patient, and in between is the system. We are trying to digitalize. So most important the healthcare setting transforming into digital platform. So what are the components where we are doing here? E-hospital, health, and that's everybody that target those aspect in the so e-office, e-health, hospital. In that most challenging thing that we are facing now is the e-prescription. We are e-prescription is when a doctor is seeing a patient, recording this history and transforming into the digital platform history. And when the patient sees, examining a patient and the signs and the symptoms, those things into writing in the electronic no, format and a platform, it is time consuming by the doctors. So there is not much of time to do that. So how we are going, we have gone into the stage of e-prescription. That is the important thing. So that probably it will be a complete digital platform for providing the service to the patient. Everything is digital, no paperwork. So this is the only area where we have to start and we're struggling almost. We are going for it to complete the prescription part because everything there are things you can do it by we have the voice that is going to record the symptoms of a doctor repeating it. So there are many ways. So it is, I think, digital platform making a single account of an application across the world, across the nation is the important thing. Because patient may not have the data or the record of hospital when they go to other states. So when they go to other state with the hospital can easily see their whatever things, whatever treatment, what are generated and seen by the doctor in one hospital, we be transferred into the other hospital. That is the beauty. I think this is a very national the registry, and all the doctors, I think care provider registry was is for the healthcare provider. They are also recording in one platform. And there is many things I think if you go for the digitalization of the health system to definitely help the health services than and hospital. So, and the e-governance is one of the important thing. Everything comes in the hospital e-governance or good governance, and this all everything transfer to. So, I hope there are many steps to improve healthcare services by adopting all this digital technology in the healthcare system. Thank you, sir. Thank you for giving me the opportunity to share my views.
Thank you. Thank you, Dr. Biswas. I think you have stressed upon the digitalization, and I'm sure there will be a lot of questions, and because of lack of time, I don't think we'll be able to answer. Do we have some time? Madam, do you have some time? Any, any questions? I'm sure the panelists will be happy to answer. So if there are no questions, yeah, please. Can you please give mic there?
So in USA there is a MS in digital health, sir, and it's going on for quite a long time. After MBBS, the doctors can do MS in digital health. That would be very good for our country also, sir, because most of the programs, most of the e-learning and most of our statistics all are based on digital health, sir. So we also should, because we have advisor to government of India and government of Telangana, I think we should also try to at least have note prepared for having in our country, sir. MS in digital health, sir.
Yeah, that's what we were discussing. Digitalization, yes, the government of Telangana is quite interested. We have in fact at the Nizam Institute of Medical HMS system and CDAC system.
Post-graduation, sir. It is a post-graduation.
A course, you mean?
After MBBS, this MS course is there on digital health in America, sir. And that is a very successful program for last 10-15 years. It is very sort of one of many of our doctors' children are doing this course, sir. I think that would be very good if we can at least write to our government of India and from Telangana government also, our health universities to have similar course.
Similar kind of a course.
Yes.
Yeah. You want to answer?
Thank you, sir. That is a really great point you brought up. Actually, when it is going towards digital health, the boundaries of, doctor, engineer, these kind of career boundaries which do not exist, they exist in our minds, they are blurring. What we saw during COVID was the people who were serving in the hospital had certain ideas and certain experiences, whereas the models that were made by people who could not ever enter the hospitals. There was a large gap. The models were made by people who are tech savvy and in coding, in ML, AI, and are not all those things. So all of us know that there were many models, but none really predicted, nowhere around the globe. And that is where we actually have felt the need for a health force, which is a bridging kind of a force between the medical and the technical, careers or lines of working. Because the way a computer engineer's or a computer techie's brain works, it's far different than how a doctor thinks. It does not happen every time 2 + 2 4 inside a human body. All of us agree. But for a coder, it has to be so. So the codes or the programs have to be made in such a way that they address medical problems in real time. But do doctors have to learn coding for this? Maybe a few. need not make the programs, but they can be this bridging force which can tell those who are hardcore techies what we require, what the problem is, so that he can provide a solution. So digital health, when you're talking about a course, yes, these courses are in pipeline. There are IITs across the country who are working towards it, along with the medical Apex institutes for digital health. And digital health has a mix of trainings. So there are some people who are hardcore computer and then AI, ML specialists, along with doctors in various fields. And it's a let's say mix. It's a good combination of teachers, trainers, which can provide digital health training for not just doctors, even computer graduates or engineers who are coming towards the newer futures, the professions which have not existed before, and now they are existing in a big way. These courses are in pipeline. In fact, few of them are already out. We all are working on it, sir. Thank you, sir. Thank you very much.
Thank you very much. And if there would like to...
Yes, as you said, it's true. When you talk about the digital health, it comes from us only. Whatever they implemented by the government of India, or it may be a government of Telangana or government of AP, almost 156 different programs they are running in a different apps. So every time, whenever we get any type of issues, like a TB program is there, so under Nikshay, so everything we will enter into the Nikshay. Now the real-time data we can do it, the budget, the financing, everything we are doing, and then we are updating everywhere. Even in Telangana, there is a Talli Bidda RMNCH program, and then they're doing it. So every Likush, and now HMIS data, as sir said, IDSP, IHIP portal, that's the one, epidemiological surveillance, entomological surveillance, so wherever the emergency response. So we are going towards the digital mission programs, and as you said, PMABeam, under the PMABeam we are doing Abaka Arts and all these things, Ayushman Bharat programs, E-Sanjeevani, E-Digital. So as sir said, definitely, and then after the MBBS, if they have a knowledge about the digital health, really it will be helpful to the doctors and as well as to the community. You rightly pointed out, sir. Thank you.
Thank you.
Thank you. I thank all the panelists for a fruitful discussion, and I close the session. Thank you very much.
Thank you. Thank you so much, sir. Of course, it was very wonderful to have different perspectives about the challenges and how to mitigate them. I request the guests to please stay onto the stage. And now, we are joined with our very esteemed guest for the day, Dr. Karthik Adappa, IAS Special Secretary, Public Health and Family Welfare Department, Punjab. Can I request you to please come onto the dais, sir, to give away mementos to our speakers here on the stage. Can I please request Dr. Anuradha Meadow-Juice to please come forward to receive a memento from a speaker. Further, can I request Major Dr. Ashlesha Taude Kelkar to please come forward. Call upon Dr. Nagari Birappa to please come forward and accept the token of appreciation. Can I call upon Dr. K.V. Ramana Reddy, Dean Mallareddy, Dental College for Women, Hyderabad. Can I further call upon Shri Sharat Anand Chupali, MD, Shiva Medisoft Services, Hyderabad. to the next part of our summit now. We have an industry presentation on SaaS analytics by Shri Prashant Rai, Senior Business Solution Manager, SaaS India. He is a domain expert for SaaS in public healthcare and insurance who is engaging with customers across central, state government and insurance companies in India. He leads the analytical efforts for SaaS that won fraud management programs with some of the largest central state government healthcare programs. He works as an expert in application of path-breaking artificial intelligence and machine learning use cases with Government of India. I request you to please take over, sir. Thank you.
So, am I audible? Okay. So, hello and welcome everyone. In fact, the last panel discussion, connected me the topic where I wanted to come. So, the esteemed panel left me left the discussion on digitalization. So, digitalization as a concept is very interesting, and I think in the last 1.5 decade, our country has generated tremendous amount of data. Now, as a concept, everyone knows that having a diagnostic report on the WhatsApp, decreases the time of travel. Or probably you may see the report quite earlier. You can click the link and could see the report, how the outcome the diagnostic has come. But I think that is not the limit of digitalization. So, if you can read your report, probably you can show it to your doctor, is the individual healthcare. And definitely, the digitalization has revolutionized that part of the world. But do you think these PDF reports, or for that matter, those X-rays, or tomography, computerized tomography scans, those can be read into the computer as well? So, imagine a doctor. Everybody is human being. So, a doctor may have seen thousands and lakhs of the tomography report in his entire career. But is it possible for the doctor to remember the structure of the area of interest? Probably not. A CT scan which may have come before the doctor probably a week ago may have one tumor into the tomography with a size, say, 1 millimeter. And probably N plus 7th day, he again gets the tomography report and he sees that, okay, there is no difference between the area of interest. Probably the same person who submitted his report a week ago, he has same area of interest like this digital space. In fact, lakhs of the CT scans can be, extracted. The features of those scans can be extracted and made sense out of it. So you will be able to see that probably the N minus 1 lakh patient that you have seen probably 2 weeks ago had this character under certain circumstances having a particular symptom, and how those symptom has progressed and how it is reflecting in next CT scan. That is the kind of invention or revolution which has come through AI. So in the next 15-20 minutes, I will take you through, I will need your attention on 2 distinct topics. One, how patient outcome has been revolutionized through the application of AI in healthcare. And second, because the paucity of time is there, so I have picked 2 use cases which we have implemented across the globe as an organization in the healthcare space. So starting with the presentation, these are the 5 areas, and probably when we were talking about the public healthcare, knowingly, unknowingly, we talked about all these 5 areas. The first is resource management, and we all know in a country constrained with the resources, if you can apply something which can make doctors and patient relationship, which is effectively one-to-one right now. So a super specialist sitting in one hospital in Hyderabad can attend one critically ill patient. But can we make this relationship one-to-many? Is it possible for multiple patients to send their diagnostic? Is it possible for multiple patients to, narrate their symptoms? And is it possible for a doctor sitting into Hyderabad treat a patient up to a certain extent in Warangal? Or for that matter, he can treat the patient in Chennai as well. So is it possible to augment the resources? Is it possible to augment the human resource as well as the infrastructure of the health through AI? I'll show you how. The second is population healthcare. Everybody talked about population healthcare, and I think post-COVID era, we all realize how a technology in population healthcare can save millions of lives at a time. Clinical decision. I mean, again, in post-COVID era, most of us would realize that, I mean, had it been a normal world, the vaccination of COVID may have taken years to get invented. But look at the kind of work they have done. They have been able to, invent the protein-based vaccination within, say, 6 months or 8 months. And it is being, distributed far and wide across the country as a protection against this virus. So clinical decision in drug discovery. Then disease surveillance. Somebody was, Steve Gates was talking about the surveillance of the disease. I mean, in a world which is growing tremendously in terms of population, we have Earth reacting into different ways. I mean, the weather is changing, the water is changing, the environment is changing. The relationship between population, the relationship between the character of the Earth is not linear anymore. It has become absolutely non-linear. So how those existing diseases are mutating, straining, and where the new diseases are coming. It is imperative for the public, for the government and public healthcare at large, to detect the advancement, the strain in evaluation. I mean, the government is choosing to invest billions of dollars into the healthcare, and it is rightly being done. But do we have the technology to measure the impact of that billion rupees or $1 billion? Because in no point of time in the future there will be a day when we will have sufficient money. That has to happen to measure the impact of investment. And these 5 areas, in fact, in these 5 areas, in fact, AI is making rapid progress. Now, all these are concepts. Does it translate into the real use cases? Are somebody working on this? The next slide talks about it. Look into this. These are the top 6 areas in which AI is making rapid progress. The first of it is medical imaging. I mean, just to let you know, and probably all of us know that, the mathematics behind artificial intelligence is not something which is very new. I mean, if you look into the advancement of mathematics and statistics, probably 18th, 19th, and 20th century, the mathematics advanced itself more rapidly compared to 20th century. So you will see a lot of mathematicians from those era, all the algorithms, all the theorems, corollary, all the validations. Those are all, the most important mathematics, which is the relationship between energy and mass, was discovered probably in the middle of the 20th century. What revolutionized this space? The revolution came into this space in the last 20 years since the advent of computing power. The mathematics was put together with the computing power, and that is the origination of artificial intelligence. And the case in point is medical imaging. As I told you, for a doctor or for someone, anyone, a pile of 1 lakh CT scan, 1 lakh USG, 1 lakh X-ray doesn't make any sense probably 10 years ago. It was absolutely nonsense. Okay, this is a pile of paper. But we knew that the pile of paper where these X-rays are, they are all in pixels. We knew it probably hundreds of years ago. We knew that these are pixels. These pixels are in fact a number. It is a representation of mathematics. Your face is representation of some number. If there is a variation in the pixel, you can extract a feature. We knew it. We knew it quite well. But we did not have the capability to extract those features because those matrix structure and the final, the feature had a lot of nonlinear relationship. In order to extract any feature, we had to do a lot of calculation. That was not possible. The AI comes exactly at that point, where you can extract the feature of a medical document. You can figure out the abnormalities out of a CT scan. The CT scan is going to locate you the exact area where it compares, and how it comes up to this conclusion. It can relate lakhs of images. It can compare the current image, and it will tell you that compared to the image which I have seen in the past, this is the abnormality which is there. It can detect the moving colors. I mean, in the cancer treatment, I mean, most of you, the experts, doctors are here. They know that shape and color are the important, point through which you identify the stage of the cancer. You take the decision in terms of where to go from here, what course of treatment you will take. That is where medical imaging has been revolutionized. Disease outcome. I mean, imagine a situation. I treat one patient at a time. I know the symptom. I give them some kind of treatment. But imagine a situation where I have complete life cycle of say 2 million patients. You have the profile of those patients, and you have the intervention that you had taken in the past and what kind of outcome it generated. Now you have new patient. You can compare the profile of that patient with the current patient with the average profile of the patient, 2 million patients who have come in the past. You know what kind of intervention I have given for this profile and what intervention resulted into the betterment of the quality of life. That is the kind of impact AI and machine learning is making. Precision medicine, again, these two are the connected topics. Drug discovery and development. Virtual assistants. I mean, in the last 3 years, this space is again very revolutionized. We lost 500,000 people in the COVID in the last 3 years, reported. And then I think double of that unreported. The most unfortunate part is that we lost thousands of doctors. We lost thousands of paramedics. A report says that if virtual assistants or telemedicine could have introduced at that time, the mortality could have been reduced by half. So we could have saved this precious resource. I mean, being a doctor in India is itself precious. The proportion, the weight of one doctor is probably 14,000 per person across the country. So we could have saved multiple lives who are very valuable if application of AI in virtual assistance and remote monitoring could have been introduced. So these are the 6 areas which is the use case currently for the AI and ML. Moving forward, I will take your time, a minute on how medical imaging is being used. So, as I told you, medical imaging works on the concept of feature extraction. And feature extraction is about locating the right point into the entire, the report, whether it is X-ray, whether it is, USG, whether it is CT scans. So those are the data set for the medical imaging. Second, what intervention you can get out of it? You can really locate. I mean, as a human, it will not be possible for you to remember all your interventions that you have done on multiple patients in the past. Probably you will not be able to remember the abnormalities. In fact, in a complex structure of CT scan, you will not be able to locate the abnormalities. And then there are multiple reasons for it. Medical imaging through AI is going to give you that capability. And how it has helped? It has reduced the diagnostic error by 80% for some of the diseases. And when I say 80%, I mean you can measure the impact of this 80%. A wrong diagnosis, a wrong prescription, a wrong prognosis can lead to disaster. So when I say 80%, it is a big number. It reduces the reliance on the human intelligence. I'm not saying, ma'am, in the last discussion, ma'am was saying it is absolutely not possible to replace human with artificial intelligence, and that is absolutely correct. 100% correct. It is only possible to bring artificial intelligence closer to the human. Never it will be the case that, it will be possible that your entire detection, prescription, prognosis, all will be handed over to the, artificial intelligence. But there is a possibility that we can improve it. Disease outcome and precision medicine. I mean, we have done this exercise at multiple places, where if you bring together all the different data sets, probably the physiological data, probably the socioeconomic data, climatic change, most importantly, the genomic data. If you bring all this data together, and then you have the course of treatment with you. So for example, I am Prashant Rai. Where do I live? What is my demographic profile? A pattern, oxygen saturation at different health touch point. Then you have my socioeconomic data, how much I earn, how I live, where I live. Then you have my genomic data and what treatment you have given me under certain circumstances. I came with N symptoms. I came with Y symptoms. What intervention you did and how that intervention led to the better quality of my life. If you have these data, this is called patient outcome data. If you have this data in store, you can take better decision. Third is precision medicine. So as a doctor, I'm not a doctor, I assume that in a situation where a patient comes to you with certain kind of symptom, he narrates the system to you, and in your mind, there are 10 possibilities which emerges for the course of treatment. Okay, should I go this way? Should I go this way? Should I go this way? In a critical situation, the success rate of each course, if you are thinking 10 ways, is just 10%. Then another technological advancement is diagnosis. So you suggest some kind of diagnosis. And then you reduce that 10 different ways probably to 5 ways. You say that, okay, those 5 hypotheses are incorrect. Let me treat this patient 5 ways. Suddenly, that 0.10 probability of the success of that way increases by 100%, which becomes 0.20. But is it possible to reduce it even further? That is the work of the precision medicine. You have got 5 ways right now, according to the symptom of the patient. But if you have got the profile, if you have got enough intelligence, you can reduce your 5 ways into 3 ways and look at the dramatism of the probability. First, the success rate of each route was 0.10. After diagnosis, it increased to 0.20. And after, precision medicine, probably you are sure that this patient belongs to a particular cluster. I had given treatment in such a way into that cluster, and if I give this medicine, probably the quality of life will be better. And now probably you are done with the 3 ways or 2 ways. Look at the probability transmission. 0.10 success. In second case, 0.20. And after profiling and precision medicine, it increases by 0.50. That is the kind of, improvement you can make through AI. Next 3, I will take a very, very brief time. Drug discovery and development. In fact, and then I told you, the miracle that India witnessed. We have been able to, bring a protein-based vaccination in 6 months, 8 months, I'll say. 2 vaccines we have been able to discover. Was it possible, probably, was it possible for the world to think about discovery is a extremely tiring and complex process, and rightly it is complex. In fact, a medicine which was discovered in US is going to be consumed by someone in the Kerala. Now you see the diversity. Some seconds in health of 1 to 1 could be but there is a huge potential. But there is a huge potential. And the way digitalization is growing, probably it will reach up to the different level probably in 2 years. So I will wrap up this section with a very alarming report. I mean, all of you can access NHS UK, National Health Scheme. We will be able to decide the diagnosis, prognosis. We will be able to decide the way of treatment much faster with greater accuracy. And that is where the next part of the world is going to revolutionize this space through AI. In the next few minutes, I will talk, all of which I talked was concept and use cases. Here are some of the statistics. And this will get you a clear idea that AI is not a mutiny, rather it has become a tempest and it is knocking your door. It is at your peril that you are ignoring it. So the report says that medical error in diagnosis has come down by 85%. And treatment error, improved diagnostic discovery. So this report is from the skin cancer, and those who know, identifying early skin cancer through the application of AI. Similarly, increased efficacy in radiology. A company in North America has been able to discover the medicine for fibrosis in just 4 days. In just 4 days by the application of AI. Similarly, there is a tremendous application of AI which has brought quality care in the area of personal treatment plan and efficient resource allocation. From here, just 2 slides, and because the constraint of the time, I have cut down on the slides. I have some powerful implementations in India as well. We have done some powerful work in Indian health space, but I will talk about 2 healthcare cases, one at the community level. And probably I have given, and this project is called Healthy Nevada, where the objective of this entire exercise was to risk score every person of Nevada community based on the different data sets and predict as to for which disease they will fall in the future. So the government has clear visibility that what policy I am making. I know the risk score of every patient. I know the health profile of my entire population. So imagine an emergency situation, a pandemic, endemic. This will make government absolutely visible. They will take such a step which will have positive outcome, which will have maximum impact, which will have maximum reach. And how we did it? We collected the data. And we created those models. Ma'am was saying that doctor cannot be a modeler. Probably he cannot be a coder. So you will have to interpret the result in such a manner that a practitioner can understand it. Giving a probability number, saying that, okay, this doesn't make sense absolutely. You will have to tell the practitioner that these are the problems, these are the issues, these are the health profile, these are the socioeconomic profile, these are the genomic profile, due to which the probability of this kind of probability has, out of all the implementation which we have done, it is the domain which leads the concern. We are the backroom boys. And that is how implementation of AI has done wonders across the globe. So absolutely agreed on that point. So in Healthy Nevada, I told you the objective, and the data set was very simple. And this data set is available across facilities, the collection of genomic data, which plays the group of patients. The government knows that if there is an explosion of obesity, which patient I should tackle to first. If there is an explosion of cardiovascular disease, which group of patient I should go to. If there is explosion of mental disease, which patient is going to fall to your facility for the European Union. Through the application of computer vision, we have automated the detection and diagnosis of colorectal cancer. This program is going on right now into that department on this topic in India as well. So the objective over here for the UMC is to apply computer vision on the tomography scan and figure out the presence of malign area into the CT scan, which could be missed by the human. And then this program has absolutely a successful track record. With this, again, I will invite the research community working into the public and personal healthcare we are working on 20 killer diseases which can turn to be a disaster for the humankind in the future. And we invite, I have, sorry, this screen over there, I have, listed down some of the effort that we are doing in cancer, but this is not limited. We have more than 200 researchers going on in cancer and beyond cancer for other 19 diseases. We invite each one of you to get in touch with us. We can collaborate and make the healthcare space better through the application of AI. Thank you.
Thanks, Mr. Prashant, for this innumerous thoughts about the AI and analytics intervention in the public healthcare sector. It was really insightful. To thank you, can I request Prashant Rai to please come onto the stage? And can I request Dr. Shafqat Khan, Additional Mission Director, AB Digital Health Mission, Jammu and Kashmir, to please come onto the dais to give away a token of appreciation to Mr. Prashant Rai here. I request everyone to quickly visit the stalls. We have some interesting medical solutions placed in the stalls at the expo. We have the inauguration now, so that we can proceed with the inauguration of the expo. Visit the expo, then we'll have a quick high tea, not more than 10 minutes. And then we have some interesting panel discussions also scheduled. So request everyone to please finish visiting back to the hall as soon as possible. Thank you.
Secretary and Mission Director, National Water Mission, Government of India, and Ministry of Electronics and Information Technology were part of the event. Speaking to a jam-packed audience, At the Bhupen Hazarika Auditorium, Jayanta Malabarua, Minister for Public Health Engineering, Skill, Employment and Entrepreneurship and Tourism Departments, Government of Assam, assured the gathering that the government was facilitating investments in a big way and has a policy in place for ease of doing business. Even a message over WhatsApp would be enough to kickstart the process, he said. Dr. Om Manchanda, Managing Director, Dr. Lalpath Lab said that Assam has huge potential to take advantage of the opportunities the healthcare sector has to offer. And echoing the sentiment of the Health Minister, who earlier in the day said that Assam can become a hub for medical tourism. He added, healthcare is the 5th largest employment sector in India and is insulated from outside issues and will not slow down. A special edition magazine, Assam Rising, showcasing the socio-economic cultural aspects of Assam, was unveiled on the occasion. Over the 2 days, industry leaders, academia and senior government officials from across the country discussed and deliberated on a wide array of issues. Speaking in the panel discussion on education and skill development, Abhishek Bose, Director, Public Sector, Microsoft said, "We already have signed an MOU with Assam Skill Development Mission, wherein more than 3,000 students have benefited out of the scheme, and we are looking to help at least another 20,000 more." Professor Jiten Hazarika, Vice Chancellor, Dibrugarh University said, "We are thinking of collaborations as well. We have already started the certification program for Korean language so that our students can learn and gain employment in Korea." Similarly, CEO of sector skill councils, namely textiles, beauty and wellness, plumbing, gem and jewelry, iron and steel, media and entertainment, spelled out the action plan for the state of Assam. Sunitha Bhuyan, noted violinist and vocalist, explained the power of music on the body, mind and soul.
From the desert in the west to northeast in Assam, Bholuka Bahore. Sao hat bilak man bihu nisnar kok ban logak ya. Akhi oi moina.
Interspersing her talk with a musical rendition. Nowadays, all over the world, music is being developed as an aid to medical care, she said. The expo, with more than 36 stalls, attracted delegates over the 2 days of the summit. Software companies and reputed institutions showcased their offerings to the teeming crowd. The 2-day mega summit had all the ingredients. Leaders in respective fields shared their knowledge. Companies showcased their offerings. Students benefited from expert talks. And the 1,700 odd students from different colleges and schools in and around Guwahati soaked in the atmosphere, which was electrified by the music of Sunitha Bhuyan, Suman Datta and the Bihu dancers. It was not the usual conference where one speaks about what ought to be, but rather provided solutions for problems. A recruitment drive was conducted on the sidelines of the summit, resulting in students from Assam, especially from the science stream, given job offers by RE Sustainability, a Hyderabad-based company. Sujeev Nair, CHRO, RE Sustainability, handed over the offer letters to the chief guest, Sri Ranuj Pegu, Minister of Education, Government of Assam. The potential and energy of youth in the Northeast is unparalleled, and so is the passion for adoption of new technologies and services, said Abhishek Singh, IAS, President and CEO, National E-Governance Division, NEEGD, MD and CEO, Digital India Corporation, and CEO of Karmayogi Bharat, Government of India. Assam is poised to turn into a medical hub. Bhaskar Rao, Founder Chairman KIMS, and KT Devanand, Regional CEO, Telangana and Andhra Pradesh Cluster, Aster, DM Healthcare, evinced interest in expanding healthcare services to Assam. This apart, Microsoft, Google, HCL Technologies, PV, Callgood, Senior VP, Education and Skill Development, Tata Technologies. ANSYS and several other bigwigs showed interest in collaborating with the government of Assam. The Telangana Academy of Skills and Knowledge Task CEO Shrikant Sinha said that the talks with the government were fruitful and Task would be working with the government of Assam in the near future in skilling youth. The indiGlobal Bharat Summit 2023 was organized by indiGlobal Media Network in association with the Government of Assam and IIT Guwahati.
I'm delighted to know that indiGlobal Medi Network, in association with the Government of Telangana, is hosting the second edition of indiGlobal HealthCare Summit on July 7th, 2023 in Hyderabad. This summit is going to be a national health leadership event with participation from policymakers, healthcare leaders from the government, both the center and state, hospitals, technology, pharma, research, and education sectors. I'm joining important summit to be hosted at Marigold Hotel in Hyderabad as a special guest speaker. I'm looking forward to meet and listen to some of the other important speakers and delegates joining the summit.
In the exam rising that concluded recently at IIT Guwahati was a huge success for more reasons than one. Over 3,500 delegates attended the two-day mega conference, which included a wide spectrum of topics ranging from education and skill development, creativity, well-being, and leadership through music, building future-ready healthcare ecosystem, sector skill councils, skilling and employment opportunities in tourism, vocational and technical education, food processing and agri-businesses, role of higher educational institutions, skills and attitudes for employability of students and youth of Northeast, handloom sector, its opportunities and challenges, emerging and future technologies, skills required for cancer cure treatment, skills for sustainable development, environment, and green jobs. The summit kicked off on a high note with a message from the Chief Minister of Assam,
indiGlobal Media Network, indiGlobal Bharat Summit 2023.
Himanta Biswa Sarma, and was followed by Program Director Sudhir Gautam, founder and CEO, indiGlobal Media Network, welcoming the guests. In the presence of the program chairs, B. Kalyan Chakravarti, IAS, Principal Secretary, Skill Employment and Entrepreneurship, Department of Labour, Government of Assam, Dr. Lakshmanan, S. IAS, Secretary, Industries, Commerce MP, Department, Government of Assam, Ankur Jain, IPS, Mission Director, Assam Skill Development Mission, and Professor Parmeshwar K. Iyer, Officiating Director, IIT Guwahati. A galaxy of personalities including M.V. Satish, Whole-Time Director and Senior Executive, Vice President Buildings, L&T. Dr. Om Manchanda, Managing Director, Dr. Lal Path Labs. Dr. Bhaskar Rao, Founder Chairman, KIMS Hospitals. Sandeep Alva, Vice President, Value Labs. Shereen Lalthangzo, Economic Advisor, Northeastern Council, Government of India. K.K. Dwivedi, Joint Secretary, Ministry of Skill Development and Entrepreneurship, Government of India. Radhika Rastogi, Special Director, Lal Bahadur Shastri, National Academy of Administration, Mussoorie. Professor Kannan Lakshminarayan, Professor of Practice, Department of Engineering Design, IIT Madras. Subbaraman V, Senior Vice President, HCL Technologies. Amit Singhal, Head Business and Transformation, Skill Initiative, ANSYS. Punar Janu, Partnerships Head, Government Affairs and Public Policy, Google India. Abhishek Bose, Director, Public Sector, Microsoft. S.K. Barwa, Senior Consultant, National Skill Development Fund, Ministry of Skill Development and Entrepreneurship.
That every one of y'all had good tea and biscuits, so you can clap a little louder for all the panelists who would be joining us. I would like to call upon the other panelists who will be joining us for this discussion. Dr. Ratan Kelkar, IAS, Secretary, Medical Education and Executive Director, State Health Authority, Government of Kerala. Request you to please come onto the dais, sir. Further, I would like to call upon, joining him would be Dr. Bijoy E., Joint Director, Operations, State Health Agency. I would like to call upon our key speaker, Dr. Karthik Adappa, IAS, Special Secretary, Public Health and Family Welfare Department, Punjab. Further, I would like to call our other key speaker for the discussion, Dr. Shafqat Khan, Additional Mission Director, AB Digital Health Mission, Jammu and Kashmir. The other panelists for the discussion, can I call upon Professor Dr. Gangadhar, MD, DM, OSD to CM of Health, Technical Advisor, Department of Health, Medical and Family Welfare, Government of Telangana. Moving ahead, can I call upon Ms. Indrani Lashkar, Joint Secretary, Health and Welfare, Department, Government of Assam. Joining us, other two panelists would be Dr. Subodh, Professor and Director, Center for Healthcare Management, Director, ASCI, PGDM, Hospital Management, Hyderabad. And the final panelist joining us for this discussion would be Mr. Prashant Rai, Senior Business Solution Manager, SAS India. We have Dr. Ratan Kelkar who has joined us virtually. So he will be there on the screen. The moderator can pay attention to that.
This technical session panel, because I do understand that we have an inauguration plan and also it's a pre-lunch session. So we will make sure that all the panelists are quite crisp in their comments, and also we will have some time for questions from the audience, because that's also very important, because we have very, representing multiple states and different fields. So always want to know, right? What is data telling me? And how do I use it? And how can we make it more for better informed decisions? How can technology help? And what is the future that holds, and what are the challenges? I think that's what we would cover in this panel, with the experiences from the states, at the center, at the academia, and at the policy level. So we have representations from the political side also. So I would also look at that angle as to how data can help their decisions. To start with, we have Dr. Ratan Kelkar, who is the Secretary IT and also the Executive Director of the State Health Agency, Kerala. So welcome to the panel, sir. And I know that you have worked in the health department for quite a long time, and now heading the IT department also. So how can we enhance better use of data through IT integration, especially when Kerala has been declared as a fully e-governed state? Your comments, sir, on that.
Before I answer the question, am I audible? I'd like to know
Yes,
that
sir.
first.
Yes, sir, you're audible.
Okay, excellent. It is indeed a wonderful event being organized. Unfortunately, I couldn't be there. So using the formalities of IT, I could at least get an opportunity to join this online and in the virtual mode. And that is indeed one of the benefits of IT. And Kerala, as you have rightly pointed out, has declared Kerala. What we are looking at doing is bringing everybody onto the IT platform, all service providers in all the departments, mathematical, mathematical data or just an information if you do not act upon it. So what makes information very relevant is the most important aspect which we have tried to address. We have tried to use the data which is coming from the field, mainly for our monitoring and evaluation purposes of various health schemes, as the vertical in the health department. Similarly, monitoring and evaluation is the core which we are insisting from the IT department to all the departments so that they take a stock to where they are heading. Generally, in a program, in this particular context, the health programs or the PMJ and other health schemes which are being operated either by NHA or by NHM. So what we generally see is we are in the process of implementing programs, and we are all in a race where we are trying to achieve deadlines and goals, whereas we somehow down the line we miss looking at the data which is giving us a reflection from the field and taking any corrective action as we go along. So this is one which has led to the schemes not being implemented in the right earnest, or we are not getting the true value for our inputs. So what we have tried to do is create a mechanism of continuous monitoring and evaluation, looking at the data and analyzing the data so that we can take course correction and also important policy decisions for the health programs to be implemented in a better way, and also for not only health vertical but also all the departments so that they have a look at their schemes. So the most important point of analyzing a data is to give a feedback to the implementers, to the policy makers, so that they can take course correction and implement the program in a much better way by appropriate policy level interventions. So that is what we have faced. And one of the success stories is the state and agency, which has very meticulously followed upon the data which is coming from the NHA IT system, the insights. We have also a state where we look at the data and take corrective measures. So this way we have been able to improve the implementation of PMJ, and we have also been able to implement and also coordinate with other departments who are handling health schemes and take over these schemes. There are good success stories which my colleague Dr. Vijay will probably speak about today in the forum. So we've been able to integrate multiple health schemes also with PMJ so that we bring everybody under one common umbrella. And this has been possible because we have seen benefits of this kind of a convergence by looking at data and using the feedback which comes from this analysis.
Thank you, sir. And continuing the Kerala experience, I would like to request our Joint Director, Dr. Bijoy, how did you actually work with the data to convince the government that there are multiple schemes that your state was implementing and ensure that, we have to converge these in the state of Kerala?
Thank you, Madam. And thank you for the indiGlobal team for inviting us for this prestigious program. And regarding the question, when SHA was constituted, the primary objective was to integrate all the other health financial schemes to single umbrella. So what we did is, as a first point, we initiated with the Karunya Benevolent Scheme, which was implemented in Kerala, run by the lottery department, and the revenue was generated from selling on lottery. So it was implemented separately. It was totally not IT-related system was managed there. So the first thing we did is we integrated the KBF system, Karunya Benevolent Scheme, into the PMJY IT platform. And we analyzed the data after 1 year. So after observing the data, we could identify that we can save a lot of money after integration the schemes to the similar platform like ABPMJY CASP. So after analyzing this, we could able to convince the government that we could save money because if we able to integrate all the health-related financial schemes to a single umbrella. So after that only we got the direction for integrating another scheme, which was Arogya scheme, which was a completely state-sponsored scheme. So last year onwards, we started implementing the Arogya scheme. This year, we privileged to integrate a lot more schemes, which was run by the other departments like Kerala Social Security Mission, like Talolam, Cancer Suraksha, and Sudhidarangam scheme, which was completely sponsored by the government-funded scheme. So this year onwards, we are integrating that scheme also to our ecosystem. And for other schemes also, which was run by other departments like labor departments, and also we are planning to integrate with this. This thing which we able to do, that we could able to convince the government after analyzing our data, the data which was available with us in the IT system. That is a success story that we were able to convince the government for integrating all these schemes. Thank you.
So definitely this is one example of how can you improve the efficiency of your scheme implementation by using the data that you already have, and also look at how that can have cost saving implications also, because it gets run by a single administration and a lot of parallel complementary benefits would also arise. So that's an example of how you use data within the government and make the decisions and convince stakeholders to agree for the changes or the reforms that you propose. We have with us from Punjab's Special Secretary Karthik sir. Sir, data analytics is a core component of public health management. Can you share an instance where this has shaped public health programs or the design of some reforms in Punjab?
Okay, thank you for a great question. I also recognize that the audience typically are all medical students. So I want to kind of start a small anecdote as a medical student, because I'm a medical doctor by training. I did my MD from All Indian Institute of Medical Sciences in internal medicine. And then I came to work in the IAS in Uttarakhand, then worked in Punjab, and essentially largely in public health work. And then went on to do a master's in public health from Hopkins, and then did a PhD in health informatics from University of North Carolina. Now, the reason why I'm sharing this journey is when I went to medical school, we hardly had any technology. So leave apart data analytics or advanced AI and machine learning. So what I want to impress upon the young medical students sitting here is no longer should medical students just think about just clinical medicine and practicing medicine. It's so much more important to have engineering skills along with medical skills. And that is by far one of the reasons why in the US, there's a school in Chicago, in the Illinois state, which actually has medical training and engineering training as a part of the medical school curriculum. So that is, I think, the need of the hour. Now, coming specifically to this question, I will give you some examples. Now, I do research in top-end medical schools at Yale and Stanford at UNC. Those are examples which, of course, are at cutting edge globally. But what I want to give you examples are from India, and specifically from Punjab. So what we're essentially trying to do is, you've had an interesting talk from SAS where the speaker was trying to highlight that in terms of computer image analysis, there's a lot of advanced research that's already happened. So for example, today, if a primary healthcare physician gets a dermatological patch and he doesn't understand what could be the potential diagnosis, now with AI and machine learning, you can actually get a variety of differential diagnoses that this tool, AI machine learning tool, can help you in. Similarly, when you have the fundus image for a diabetic retinopathy, it's possible that you don't have an ophthalmologist in the primary healthcare, but this AI machine learning assistant can help you make some differential diagnosis. Generation physician needs to understand AI and ML is largely to understand its strengths, but also understand the risks and the safety concerns associated with AI and machine learning. So I also want to, therefore, I want to take this opportunity to highlight some of these concerns, and I know there are other speakers as well. So I'll stop it here, but I would be very interested to take questions from the audience at a later stage. Thank you.
So we do have a second round of questions on the challenges, so we will come back to you on that. But definitely it gives an idea that the government is not behind in technology, and it's not technology being applied only in the higher levels of care, but also to the primary healthcare level, which we were discussing in the previous panel, that primary healthcare is also very important. So happy to see the progress in that space. Gangadhar sir, specifically access to data and integration of multiple health information systems has to be ensured to make meaningful inferences, not only to the decision-making body, which is the technical, but also to the political leadership. What steps have been taken by Government of Telangana towards this, and how do you see it moving ahead to help the political leadership also to make such decisions?
Thank you, esteemed analysts. So basically, I'm also a doctor, as sir was telling. When I was in MBBS, only bedside teaching was there, where our data is coming from only bedside. When I moved to Nizam Institute of Medical Sciences, then I went to Harvard for research. Then there's a called bench to bedside. But later on, when I came back, it came to bench to bedside to, again, bureaucracy. When we are making a policy, there are three levels of communication. One is scientific communication, second is a political communication, third is a public communication. Wherever it is there, now I am working as always to the Chief Minister of Telangana and also technical advisor, where my job is to make the scientific communication palatable to the public and also to the political people, where this data emerging from scientific basis need to be communicated in a way the political system will understand and the public also understand. Because in a democratic country, a lot of solutions lie with the political solutions only. I'll give an example of, I'm a nephrologist basically. So what is data means, how to convince the political system to make a universal health coverage in at least in kidney angle. So let us say I was actually returned from Harvard, where in 2014 when Telangana was formed, I was inducted into the ministry as an advisor to the Honorable Minister at the time. So basically the kidney care at that time was not universal. Dialysis was not given full to all the population. Then we generated the data. How many patients are there in Telangana state who requires dialysis? Then where we should keep the dialysis centers? How to manage them? Then how can we fund them? So these sort of data was generated and the political people were briefed. The minister was briefed, Honorable CM was briefed, and public also, like MLAs were briefed. Then it became a political agenda now. Now, no nephrologists are asking for a dialysis center. It is the public who are demanding for dialysis center. It is a politician who is demanding for dialysis center in their own area. So that's how the issue was brought out in a scientific manner to them. Now issue is settled now. Now in Telangana state we are spending 100 crores only on dialysis centers, and 119 centers are there in across Telangana. Each constituency of Telangana state now is having a dialysis center where public are not moving not more than 30 kilometers to access dialysis care. That's how the issue of dialysis or kidney care was brought out in an opt manner to the public and also political system, where now issue is settled. So this is how an administrator should be briefed in a proper manner. The scientific communication should be made to the political people, political communication should be proper, then public communication also should be proper to evolve any solution. It's our democratic country. So whenever you want any solution, healthcare is one of the issue. That issue need to be properly briefed to the political and also public system, where the issue should be made to public agenda, then political agenda, then the problem will get solved. So there's only one example I have given. That's how the Telangana is moving. Like initially Niti Aayog ranking was 11 in Telangana state. That was also briefed. Now we are in third level. Our IMR at the time of Telangana formation 39. He brought down to 21. Then the maternal mortality was 93. Brought down to 43. So this is how these numbers matter. These numbers, what are the data analytics matters. And they need to be properly communicated to the administrations, like bureaucracy should be briefed, the political system should be briefed, and public also should be briefed in a proper manner. Then they become an agenda. That agenda issue should be there in agenda, that when agenda is there, then solution will come. Like maternal mortality was agenda item. 93 per lakh population was our MMR. Now full administration was geared up, political system was geared up, public is geared up. Now it become to 43 by establishing more MCA centers, by establishing high-end ICUs where agenda is there. Then after the MMR, more SNCs were there, high-risk deliveries are identified. That sort of a solution came up. Now we are in rank number 3 in the country. So that's how the political system was briefed by whatever we are. A lot of doctors are there. Apart from doing individual patient care, it's our responsibility that we are social doctor from taking care of individual patient. We should also take care of the entire society. So taking care of society, we need to brief the administration properly, the bureaucracy properly, and also the political people and public also to properly to evolve any solution. That's my experience in last 10 years I'm with the government, so this is my experience.
Thank you, sir, for emphasizing that data can be a strong lever for political advocacy. So definitely issues need to be taken up, and how do you shape it? Data analysis and insights can definitely help with that. So moving to the kind of reform that the whole country is going ahead with, the Ayushman Bharat Digital Mission is a game changer. And we have Dr. Shakat Khan from Jammu and Kashmir, who is the Digital Mission Director. So, Sir J&K...
Make healthcare much easy to deliver and for the citizens much easy to, receive. It is just a way of creating ease of business. The papers, the transactions, the records will go into repository, into a central repository in your healthcare Abha ID. Abha is a repository of your health records right from your birth till the, the last breath. And that will facilitate, number one, your entire treatment with your records. It will facilitate ease, you don't need to carry all those records. Then the child from the birth will know when his vaccinations have taken place, automatic on your cell phone. You will put your records into maybe a DigiLocker or it will be a cloud-based information. It will be a secure consent-based information management system on your, cell phone, meaning that you will be the manager of your, information. You will share it with a health institution or a doctor with consent, because, the questions of security of this data comes into, question. But having said that, since we are talking about data, what has data done to our lives? This big data we are generating in our country is of huge value to us. Please understand, our institutional delivery in J&K is 97%. Who could imagine J&K like state, which has a very huge, vast area, hilly area, difficult to reach area, can have 97% institutional delivery. Our vaccination, process is already touching 100%. And that is because it is all digitized. The COVID app has, been the win-win situation for our great country. And it's a global success story. So many people, such a huge population, got vaccinated, registered, and re-registered, and revaccinated and all. So my point is that data is going to be the future gold, and we'll have to preserve it well. There are, of course, questions of security of data. There are questions of keeping it in safe hands. And that's what the government is ensuring at the highest level, that this data should not be breached. This data should not go to some adversary. It should not go haywire. And this data is actually a huge resource to build this country into a great country, which already it is on the path of being a great country, globally. So my point here is that we had highlighted some issues. We said, who is the basic healthcare provider? The basic healthcare provider is an ASHA worker, an FMPHW, a community health worker. We have gone so far deep into providing healthcare. It is not the doctor now. The doctor maybe comes in the last. You have to understand how a prenatal, checkup for a woman till the entire 9 months. There's no doctor. There's an ASHA worker who is taking her, all the time, going to her house, taking all the notes and putting them, overutilized ASHA worker, I call her. She is hugely burdened. Whenever we have a function, we call ASHA workers, please come over. And, they turn in hundreds. They have to walk miles. We overburden them sometimes. But trust me, our peripheral health system is strengthening like anything. J&K, for example, we had 500 medical seats. Now we have around 2,000. We have 9 medical colleges. We have 2 AIMS coming up. The Government of India Prime Minister has been kind to give us 2 AIMS. We have n number of trauma centers coming. We have 2 cancer institutes coming, one in Jammu and one in Srinagar. We have also DNB courses. DNB courses just started 2 years back. And we have 260 DNB seats. Now a person from Kerala, we have students from Kerala coming to Kupwara district. And that is integration. That is the beauty of the entire integration of this country. We see that as part of integration. When somebody from Kerala, from Chennai, a student is sitting in Kupwara and Bandipur and doing DNB, Bandipur, a district which was never considered, in Pulwama. Pulwama, you must have heard for all the wrong reasons. But today, Pulwama, there are startups. There are, young minds opening cafeterias, doing pottery. We have one of the best minds. Recently, one of our KS toppers came from Pulwama. We have few IS boys coming from Pulwama. So my entire, argument goes into saying that digital revolution is, anything. Our chief secretary yesterday, day before we had a conclave, said anything which is not digital is suboptimal. It is not optimal. So we need to, put digitization in everything in our sphere. And I tell people during my interactions with, the healthcare workers and others, that please embrace digitization as fast as possible, because it will embrace you anyway. Today, if you have to buy a ticket, you have to use your smartphone. You have to, otherwise you will end up paying more with the travel agent and all. Or, book a train ticket, go for information, go into Google, find out things. So I feel that this boom of digital boom in a country is going to conquer the world, trust me. It is going to be the key to our success globally. And we as a country, as one of the earlier panels said, we are very hardworking people. We are workaholics. Indians are the best minds and the best working category. That's why we are sought all over the globe. So we can do it. I am sure if we run this the way it's going, I see huge success for this country in the coming days and years, and wish all of you good luck. Thank you.
Thank you, sir. Yes, as the country embraces digitization, I think the use of that information is where it matters. So being a joint director at your state health department, it is very important that your officers and your nodal officers at the district, at the program level, need to make sure that all that digitized data makes sense to them and how they can actually alter the course of the program. So any thoughts and experiences on that, ma'am?
Good afternoon. At the outset, I would like to thank the organizers for such a beautiful summit. And as for me, I would like to say that I'm not a doctor. I'm an out-and-out bureaucrat. So whatever I'll speak from the layman point of view and from my experience in the health department. And so far as Assam is concerned, we are not in a big way so far as data analytics is concerned, like in other states. But still, we have taken up the Ayushman Bharat. And so far, we have been able to generate the Aadhaar cards. And we have made significant progress because around 1.38 crores of Aadhaar cards has been generated. And then we also generated the health records. And then we have also taken up the wellness centers, which should be around 4,422. And then speaking of the data analytics, from my own experience in whatever small way that we had been trying, I could see it's sometimes very difficult. First and foremost, the data is there, but then it is difficult because they are not standardized, they need to be filtered. Then this is happening mostly because I totally agree with other person that the doctors, they are very good in their own profession, but then again, they are not that technically aware, or maybe because they were so much immersed in their, in the medical field, knowing well that how difficult it is to become a doctor. But then somehow, maybe because they are not that much trained in, when it comes to technical matters. So sometimes, and even if they are being given the task, they feel a bit, reluctant, like why I am doing it. Maybe in the course of time and giving the changes in the healthcare and the way that we are having, especially with the launch of the Ayushman Bharat, we will all pick up the threads and they will obviously pick it up. And I have seen signs that they are doing well also. And second, going back to the data generation and all, I think I listened carefully to Kerala experience, and this is something which we can learn from. And sometimes what happens is that, yes, we also need, so when it comes to awareness, government is aware of the importance of integrating technology with in government schemes and all, aligning the technology with the needs of the people. But then what is happening is that when it comes to the awareness, we still are learning and we still need to motivate, because sometimes what happens is that it is still like a kind of ad hoc kind of a planning that is going on. I mean, not exactly, but sometimes it happens. So that has to be worked upon. And as I said, yes, awareness need to be given, not only with only the doctors, but also as every one of us who are in the administration. Because sometimes what happens is that the person, like, okay, fine, he has to be given this work of portal and data management and all. I mean, someone who doesn't have the work, let him be dumped with that work. That is what was it, but now things are changing. That is also happening, and the poor chap, he doesn't know. And the awareness needs to be drilled into. And especially when it comes to Assam, I feel that we are also grappling with the logistical planning, and we are trying to strike up especially with the supply of medicines and drugs, which we are trying to streamline. And we are making some progress in it, and in the long run, maybe we will take rapid strides. As of now, we are still in the baby steps, and I'm also learning. Our people are also learning. Thank you so very much. Thank you.
Yeah, definitely. You touched upon standardization of data and how that would help better usage, and also on the capacity constraints. So these are two, you moved already on to the next round, but definitely these are two key challenges on how do we use data. Now coming on to the other partners with the government, especially the academia and research institutes, they can actually contribute a lot in providing feedback to the governments on various programs, because they are the third eye, because they can distill this information much better and connect and give a lot of insights. How do you think this partnership can be further strengthened with the government?
Thank you, Dr. Sudha, and other esteemed panelists. So I will answer this in around 4 points. I think let's take to the COVID-19. I think that's when academia played a very big role, especially with the support of media. I think all the data, I think, which was in public domain, I think that was a time when we analyzed. A lot of predictive analytics happened at that time, looking at the forecasting, what happens, like for example, second wave to third wave, how much is going to be the shortage in oxygen, the ventilators, a lot of sensitivity analysis. What happens if your case detection ratio is going to be 10%, 15%? So a lot of analysis happened, I think not just in Hyderabad, but in other IITs, IIMs, a lot of analysis happened, and very much picked up by the government, not just by the state governments, but by the government of India. So that's where I think a lot of analysis happened. A lot of data is there. I think immunization, everybody knew a lot of data was there, but how much was the first dose, second dose, district level, program-wise. So a lot of sub-analysis was actually done by the academic institutes. The second part, I think many speakers actually talked about monitoring and evaluation. Monitoring is done excellently well by the departments, but when it comes to evaluation, that's where I think a lot of analytics can be used by the academic institute. So they bring, as Madam said, the third eye. You can actually bring in those extra angle, bringing all the stakeholders. A lot of analysis actually happens. One of the things we get to hear always at the state level, because we work at ASCII at a lot of states, and one of the things we get to hear is, "Hamare paas bahut data hai. We have a lot of data, but what do we do with this data?" Right? And second question we get is, okay, everything is there at the state level, but how do I know a district is different from another district? How do I deal with the tribal district? How do I do it a particular program? Can we do a sort of a sub-analysis? So that's where academic institutes come in very, very handy. And the last point I want to highlighting all these things, and there's a lot of talk about technology, digital health, is about the capacity building. Who are we actually giving the training to? As you rightly said, doctors, now to get them to learn Excel, statistics, they just straight away get. But actually, again, thanks to COVID, I think now telemedicine is being accepted. I know 10 years back telemedicine was there, but now it has got a much more acceptance. I know doctors who are doing video consultations. We do have Practo apps showing you can go either online or a face-to-face. So a lot of opportunities have now come. But the point is, who are we training? Like, for example, for any data analytics, it should ideally be the monitoring and evaluation person. So we need to identify those capacity building. I can give you a lot of examples where academic institutes are now supporting the government. And I always insist on hand-holding. It should not be academic institutes do it and lieu away. We need to hand-hold the government. For example, we are working with Arogyasri Healthcare Trust, we are sort of a knowledge partner, trying to handhold them, doing a little bit of analysis, helping to get to the next level. We have done the same thing with other states on health expenditure framework analysis, looking at where the funds are going, whether it's a primary care, tertiary care, or a secondary care. Where should we be putting the money in the next 5 years? But the focus is train your in-house team along with your accounts officers. It's not just, academia cannot just survive and publish papers, but work along with the government. Thank you.
Thank you. I think knowledge transfer to the government is very key, and I'm sure that that is something when governments work with these academic institutions, they should add that as a clause. Whenever they are giving any kind of, contracts or, requests to participate and partner to make sure that there is a knowledge transfer and the local institutions can actually support the development of that capacity within the government. So, Dr. Prashant, there's a rapid progress of how data can be analyzed, presented to key officials. You had a whole session before our session. So I'll ask you a different question here. How do you co-develop solutions with the government? Because it is important that we can all come up with tools that have been worked wherever else it's been developed, but actually sitting next to the government and then co-developing it to the kind of, and tailoring it, needs a lot of effort than just developing a solutions as a standalone. So any thoughts on that and your experience on that?
Sure.
In short.
Sure. So I will begin with a very short story. So there is a Dutch statistician, John Rousseau-Fibo. He was a professor in one university. So on a fine day, he was taking lecture in the class and somebody asked that I want to do some kind of analysis. And how much data do you think will be sufficient for this analysis? This is the question, very small question. How much data will be sufficient for this analysis? Tell me. He was a very famous statistician, he contributed a lot. And he said, no, I don't know. How do I know how much data will be sufficient? He resigned as a professor because I said that, why don't you know? You are a professor, how don't you know that how much data will be sufficient? Look at the situation, we all talk about data, day in and day out. As a data scientist from the data background, I talk about data day in and day out. And people ask, how much data will be sufficient for this analysis? Why don't you know? Tell me. So he resigned from the professorship and he spent his entire life figuring out the answer to this question. He died. He never came to know that how much data is sufficient for this analysis. Okay. Subsequently, probably 40 years after his death, somebody came out with the term of hypothesis testing. Hypothesis testing, forget everything. Statistics and machine learning is handicapped if you do not ride it on the shoulder of an expert who is domain expert. I have got huge amount of data. I don't have any hypothesis. What does it simply say? I have created one code which produces regression. Now go to hell with this. You have to have some kind of statistics is about translating your narration into the mathematical equation which can produce tangible outcome. That is about the statistics. It is not that on a fine day I have got great set of data, I will just bang my head against it, will produce whatever, garbage in, garbage out, will slap those results on your mouth, do whatever you want to do with this. I don't care. So, translating your problem, that is the foremost thing which you want to do. That is the narration, which will come from the expert like you in healthcare. The second part will be some kind of statistician who will translate this narration into hypothesis. And these hypotheses will be tested against the data. And this could be acceptance of your hypothesis or rejection of the hypothesis. I was working in one organization. The partner came to me and said, look, I need all those people out from this data set who will purchase the credit card by tomorrow. Okay? Your time starts now. Tomorrow, I cannot tell him that, no, sir, nobody out of this group is going to purchase the credit card. This is not the acceptable result. Which is the acceptable result? I tested his hypothesis and found that nobody is going to purchase your credit card, but that is not the outcome he wants. He said that no matter what, the result which I wanted should come from this analysis. Go to well. Don't test the hypothesis. We want to collaborate with the government. We want the leaders like you to create the hypothesis. You have got your big department. You have got big data set. You have thought that, okay, I want to set up a thalassemia center. I want to set up a nephrology center into some part of the smaller place. You need to test. I mean, you have limited resource. So you need to know that you need to decide the pin code, priority of the pin code. In this order, I need to invest. In this order, I will invest. Only then the result will be maximum. Because at the end of the day, we are working in an optimized. We are not working in an overwhelming scenario. We are working in an optimized scenario. We want to work with the department. And it's not the precondition. We can collaborate with the state. We can collaborate with the country. Where there is a longer vision. Rome was not built in a day. The data comes later. First of all, we want to work with a leader like you who has thought, okay, I want to solve this problem. The second question will be, where is the data? Whether the data is sufficient for which that professor died. Now we have got the answer. So I tell you that, okay, this is your data. Now, I see a lot of people saying that, oh, we don't have data. Let's first collect the data. I think never it happened. Never it will happen in the future that you will have sufficient data. You will have to know that out of the data which is available right now, how I can start the first building block. So we are absolutely open to work with a leader like you, who has huge inclination towards the data, and all of us claim that we have huge amount of data. So let's collaborate to create the narration of the problem, then create the hypothesis, and then there are n number of mathematical methods through which we can ensure that even the limited data can produce actionable results. We can customize the solution for you guys. Thank you, ma'am.
Thank you. I think just to ensure that we utilize the time, I would break for questions from the audience so that we will have our panelists respond. And if there is time, then we'll go for the second round. Otherwise, we should, get a more engaging audience. Yes, please. Can you pass the mic to her? And since a lot of young students, you should ask questions. Then only we realize that, okay, we're making some sense. Otherwise, it's just becoming a monologue of people here. I'm sure if anything is, you need to clarify, please ask.
A small request, whoever has questions, please introduce yourself, and I request you to keep the question crisp and not a statement, please.
Sure. Very good afternoon to the esteemed panel. I'm Dr. Farhana. And my question is, like Sir rightly said, there's this predictive analysis that helped in COVID-19. My question is, out of the descriptive, predictive and prescriptive type of analysis, which is most relevant to the healthcare domain and why? If you could please give your expert opinion on this. Thank you. Who wants to pick Subodh? Yeah.
So again, I'll say, first of all, it is not that in a war between two persons, you choose a tank to fight with. What is the objective? And that is where I told you the null hypothesis. All these three, in most of 90% of the situation, a simple mean median mode, which is the moment statistics, can take care of your problem. The tragedy is that straight away we jump to the equation. I will create one fine regression model. No. All those statistics are absolutely important. You need to know which tool is to be applied. You test the tool against the null hypothesis and figure out the data for it. So all those things are absolutely important. You cannot put them in order. Thank you.
Thank you. Thank you.
Good afternoon to the panel. I am Sai Shri Kanda. I am a student at IIM Rohtak. And my question was about how we can, I want to know what are the biggest challenges that are there when we are trying to get telemedicine into the rural part of India. Because when Dr. Khan talked about Jammu and Kashmir and how they were to, digitalize the entire thing, in a lot of rural India, there is no electricity also. And most of our states, the other states are like that. So what advice would you have for the other states that how can they go ahead with this, or what are the challenges? That's what I wanted to know.
Okay. So it's a great question. I'll talk a little bit more about science and talk a little less about the implementation challenges, because around the world, even in high-income countries, there are challenges in terms of bandwidth availability and all. Essentially, what telemedicine, I think telemedicine has been there even before COVID. Its importance has grown during the COVID times. But essentially, what I want to highlight here is the business idea of telemedicine. Today in public healthcare in India, we've not really truly actualized the potential of telemedicine as a business idea. And when that grows, which basically means today the thinking, there's a need for a paradigm shift in the way we think about telemedicine. We think about telemedicine as only technology for people in rural areas, in areas where physicians are not available. I'm trying to propose that telemedicine is not only for them. Telemedicine is also for people who live in urban areas, people who live in metro cities. Because primarily, if you have to travel from your place to a physician, take time, and there's a lot of time that you spend even in a big city. So essentially, when technology is made available, it's not, and especially telemedicine, because that's a major shift that is happening in the US, and it will come to India as well. So what I'm trying to say is telemedicine is not just for people who live in far-off areas. It's not meant only for people in rural areas. So even in a city like Hyderabad, instead of going to the physician in person, if the technology is so good, if the usability of the technology is so good, what would happen is you would probably sit at your home, wear your pajamas, sit before a physician and say, hey, this is what I can do, this is what is my problem. You'll be able to give your chief complaints, and if you have enough adequate variables, you'll be able to give a large amount of your physical data to the physician, and then now with increasing technology, all the data points that you need over a period of time can be made accessible. So telemedicine is not just about increasing access between the provider and the patient, but it's also giving those data points that the physician needs to get from the patient. So it doesn't need that the patient has to transport himself. Now, this looks like a slightly, like an Alice in Wonderland right now. But in the US, for instance, a lot of hospitals are moving away from brick and mortar and moving more towards these virtual hospitals. Now so it is not just telemedicine alone, it is these virtual hospitals that will come in the times to come. I mean, we've not grown till there, technology and because when you build technology, you want to look at it as a socio-technical system. It's not just about creating technology, there are social realities, there are realities around human beings. And that is the reason why when technology gets adopted in healthcare, it gets adopted far more slower than various other sectors, precisely because of these reasons. So I think in telemedicine, what I would say is what we are seeing is just a small tip of the iceberg. There's much more in terms of the potential of telemedicine, both in India as well as outside. Hope that's helpful.
I will just add up to what Dr. Karthik said. Her more concern is that you see wherever there is hilly terrain, there is hard to reach, inaccessible areas where there is no electricity sometimes, maybe there is no mobility, even internet connectivity. How do you do the telemedicine for those areas? You see these challenges are for northern and northeast states and UTs. We have a huge challenge in that. Of course, we are trying to beat that challenge in two ways. We are creating small mobile units which will go to all the far-flung areas. Number one, internet proliferation and connectivity is going all through J&K, and the proliferation is almost reaching 90% now. Number one. Number two, electricity under the rural electrification program. We are trying to bring electricity to all the villages, all the remotest areas of J&K. That is the Prime Minister's vision for J&K. And number three, when you talk about small innovations, what you have done is, for example, if a person does not have a smartphone in an area of, say, Kupwara, Matsil area, or some area which is Doda, Kishtwar, Badarwa, So what we do is we make a Aadhaar card, say digital I'm saying, from the digital part of it. So the Aadhaar card will, he doesn't need a smart card. The Aadhaar card will carry a QR code for him. So the reverse scan and pull will happen. He will go to a health facility, show his Aadhaar card. The person will, from a gun scan his demographics and capture it, and then he will be logged into the system. And having said that, we also want to integrate, suppose we have TB Mukt Bharat, we have Anemia Mukt Bharat, very important programs in India, which are challenging to us. There are teams, mobile teams, which go have health checkups in those areas from time to time. Capture information, gather their statistics, have their health checkup done, and then, sometimes relay it on, come down and relay it on internet, through devices. That is what we have done. But till a robust system of internet doesn't come into the most, which sometimes seems not achievable, because people in our J&K, you will be amazed that they are living on the top of a mountain, there are 3 houses. There are, on another mountain, there are 3 houses. So that kind of approach would be only by having mobile teams which access them, do their vaccination, have health cards, Sabha cards prepared, and bring them into the ecosystem of digital health. That's my understanding.
One last question. I think lack of time, one last question, and we will then have the closing remarks for all the panelists. So then you can add in anything specific. Can they give the mic, please?
When we do clinical trials, in one arm, if there is placebo, and in other arm, the drug of choice, of investigation is there, can we accept those trials in India? Because if we have a standard of drug, like say for example, one disease is there, we have been treating with one particular drug, the new drug should be better than that particular drug. That particular trials only, if it can be accepted in India, that would be safeguarding the interest, ethical interest of our country. For example, in China, they will not allow any drug in which the Chinese population are not included in that drug trial. They will not allow the drug to be sold in their country. That mandate they keep it, and their drug controller of that particular China will not allow that drug to be sold in the country. If we can have that type of restrictions, only probably we will have a better safeguard of our patients, I think. What do you say? Is it acceptable to allow placebo as one of the arms? Because it is continuing like that, in spite of having so many advances in the trials. Because I have conducted American Society of Clinical Oncology trial in India, this particular topic, because for that same reason, the media is highlighting these trials have been used as a guinea pigs for our Indian population, because most of the trials are sponsored by multinational companies. So for that reason, I'm asking this question.
He has got the question, so he'll respond.
So it is a very sensitive topic. Let me answer it in 3 parts, and I'm not an authority in this, nor am I going to speak for the Pharmaceutical Authority of India. We have a regulator who regulates all the drugs that come to India. So I'm going to talk more from a scientist point of view, not from a bureaucratic point of view. So one, what happens is most MNCs, why do they come to India? So MNCs come to India because conducting clinical trials is much easier in India. 2, when drugs come, drugs are tested in 2 broad parts. First is safety. So first is, even before you bring it to human beings, you test them first on animals, and then you do 2 parts in human beings. One is safety testing, and second is efficacious testing, which means the therapeutic efficacy of the drug, very broadly. So first is, once the drug is safe on human beings, the second part is it efficacious? Is it giving the therapeutic efficacy that the drug is initially prepared for? Now the part that you said, what you're trying to say is a randomized controlled trial, which means you have a placebo and then you have the intervention. Now, typically, a clinical trial is just a general word, but actually what happens in a clinical trial is most often than not, it will be a randomized controlled trial. But it doesn't mean that all clinical trials have to be randomized control trial. In MNCs prefer India primarily because of the population that we have. Now the other part is, should we allow MNCs to do clinical trials in India? Okay, that's a big ethical question. Two, in China you said, but the reality is even in China, the biggest problem is for drugs that treat rare diseases. For common diseases, there's no problem. I mean, India doesn't need to depend on drugs from other countries for common diseases. It's only for rare diseases that there is a difference between the Chinese regulation and the Indian regulation. When you get a rare disease, the family wants quick treatment. Okay? People from India go and join clinical trials in the US so that you get that rare drug. Okay? And they join clinical trials in the US as well. I'm talking of those people who can afford. Now, some of these rare drugs, when they come to India and they do a clinical trial, families are desperate to get treated. And that's the reason why they join on those clinical trials. And that I'm talking from a physician standpoint. In China, because the regulations are very higher, very often what happens is some of these rare diseases, that's their country's norm, that they don't want to allow any of these rare diseases to be treated in their population. But some of these rare drugs, what I want to say is, they may not be efficacious, but they will definitely be safe. It's only when they're safe, they come to the next stage of the testing process. So some of what you read in media is not always very true. But yes, there can be black sheep, I'm not ruling that out at all. But I'm talking in general, very broad strokes. When you see clinical trials for efficacy, they're safe. They may not reach the efficacy part, but they will definitely be safe for human beings. It's not that we are being treated as guinea pigs.
Thank you, sir. I think Dr. Ratan, sir, online has a comment. So over to you.
Yeah, could you repeat the question?
I thought you had raised your hand. We had asked you for a closing remark, sir.
Sorry, you're not audible. What was that?
A closing remark for the session, sir.
Oh, okay. So I would just want to re-emphasize what I said at the beginning. I think the monitoring and evaluation is a very critical aspect. And for that, I think data is the most important input. And what we've seen is the analysis of data is not taken seriously, due to which we miss a lot of changes which can be brought about in the way in which we function. So my emphasis would be on creation of a monitoring and evaluation cell at all departments, which can continuously look at the data coming from the field and take corrections, which will give us all good results. Kerala has done that very successfully, and we are also looking at reinforcing this in all other departments. So in the health department, we have been able to create a M&E division under NHM, and NHM has been supported quite efficiently by all the relevant stakeholders. So my emphasis would be on monitoring and evaluation, which is likely to give us good results in the future.
Thank you, sir. Mr. Prashant. Just 15 seconds, I would request every panelist so that we can wrap up this session for lunch.
So just 3 crisp points. There will not be any data birthday. You should start applying data analytics in whatever form and shape the data is. That is one. Secondly, data analytics needs 2 investment. One is monetary and second is cultural investment. So you have to, as a leader, you will have to instill this culture of usage of data analytics. That is second. Then the effort. I mean, instilling a culture of data analytics in the system takes effort. I sincerely and earnestly request all of you, because you are the leader, to instill this feature in the system. The analytics brings revolution through the impact. Analytics is not revolution. So the day analytics will bring change, it will bring revolution. Thank you.
Yes. So I just want to connect with one of the questions which came when I had the opportunity after academics to work in the government, and I had actually done my PhD on a lot of econometric analysis. The first thing the principal secretary told me was, whatever you do, everybody should understand, and even a simple percentage is actually good enough. So analytics is all about how everybody can understand and make the best use. Thank you.
Thank you. I won't take much time. As my executive director said earlier, our most priority will be the monitoring and evaluation. We are all sitting on a huge data, and if you are not utilizing it in proper way, they won't help us in future planning and all. So we are dealing with we are giving most priority to the monitoring and evaluation, and we'll continue with that. Thank you.
From the government perspective, yes, government really wants data analytics to make inroads, as you have been saying, from prescriptive, predictive, and descriptive point of view. And COVID has really raised the importance, how data analysis has been utilized in planning, forecasting, and demand planning. And I'll just give a small example, like for example, why data analysis is very important. There was a study in USA where they said because of the overdose of drugs, there had identified around 742 risk factors, and in fact because of the overdose it has also led to problem of road safety. So that itself shows that how important it is as regards data analysis is concerned. Thank you so very much for your patient hearing. Sir?
I will quickly sum it up by saying that the digital interventions, whichever we are introducing in our systems. I'll give you a small example of J&K. J&K used to be a princely state once upon a time, and there was this Darbar move practice of shifting office winters to Jammu and summers to Srinagar. And imagine the cost of this practice in the government till recently was around 400 crores. Just the shifting of offices, the complete offices in Jammu along with files, computers would be loaded into trucks and sent to Srinagar. Srinagar Secretariat would get a facelift every year, and Jammu Secretariat would get a facelift in some winters when in November it used to come. So we launched e-office. 400 different departments, small, big, are now running on e-office platform. And this e-office platform has created such ease of business within the government. You cannot even imagine right now that everything, I'm sitting here, I have my e-office, I can access it, and if there is a file, I'll send it back or up or down, wherever. So this entire digital revolution has created ease of business, ease of life. And the ultimate aim is to increase the happiness index of this country. People should start becoming happy with ease of, and I wish this digital, intervention brings more and more happiness to our country. Thank you.
Use my 15 seconds as well. No problem. I've spoken enough, so please.
Yeah, my comment is actually data is everywhere. Data will emerge every time. So only thing we have to look at the data, analyze the data, and plan it for the betterment of the people. Like in NHM and Arogyasri in our state, we effectively utilize the data to create the infrastructure at the district level. Like in some districts are having more burden of kidney disease, heart disease. In wherever the heart disease, cath labs are being established. Where cancer burden is high, we made a chloropath maps also in the state. Where disease burden is there, we can plan this data for the benefit of the people. The data is everywhere. If at all you don't use it, it will be anywhere, it will be generated. Only we have to utilize the data to create the infrastructure, create the manpower to address the societal problems. That's the thing that I want to tell. Thanks.
So, thanks a lot to all the panelists for ensuring that this is an interesting session and we are more responsive to the audience. I can see everyone is charged up now for lunch. So, thank you very much.
Thank you, ma'am. It was a wonderful session, how analytics and digital intervention is bettering and changing the face of healthcare in India today. And we had a really interactive session as well, thanks to all the panelists. I would like to call forward to give away the mementos as token of appreciation to our panelists here. Please come forward, sir. I would like to call forward Dr. Bijoy E., Joint Director Operations, State Health Agency, to please come forward to receive the memento. On behalf of Dr. Ratan Kelkar, IAS Secretary, Medical Education and Executive, Director, State Health Authority, Government of Kerala. Further, I would like to call upon Professor Dr. Gangadhar Taduri, MD, DM, OSD to CM Health, Technical Advisor, Department of Health, Medical and Family Welfare, Government of Telangana. I would like to call upon Dr. Shafqat Khan, Additional Mission Director, AB Digital Health Mission, Jammu and Kashmir. I would like to further call upon Ms. Indrani Laskar, Joint Secretary, Health and Family Welfare, Department, Government of Telangana, Government of Assam. Further, I would like to call upon Dr. Subodh, Professor and Director, Center for Healthcare Management, Director, ASCI, PGDM, Hospital Management, Hyderabad. I would further like to call upon our moderator for this panel discussion, Dr. Sudha Chandrasekhar, Public Health Specialist and Health Economist, Advisor Health System Transformation Platform. Finally, the SAS specialist, I would like to call upon Shri Prashant Rai, Senior Business Solution Manager, SAS India. I would like to call upon Radha Krishna B., Director Customer Advisory, SAS India, onto the dais, please. Sir would like to hand over these SAS baggages to our panelists here. I would like to call Sudhir Gautam onto the stage, please. CEO and Editor-in-Chief, indiGlobal Media Network, to give away a big token of appreciation to Dr. Karthik Adappa, IAS Special Secretary, Public Health and Family Welfare Department, Punjab.
Thank you very much, Prerna. Dr. Radhakrishna would like to give a gift hamper to all our esteemed speakers who have joined us from across the country. To Dr. Gangadhar, representing the Telangana State Government. To Dr. Karthik Adappa. Now I would request all the esteemed speakers to come forward for a group picture over here.
I would like Dr. Karthik to please come ahead.
our panel speakers were mentioning, we will break for lunch. But before that, we have a very interesting panel discussion with 4 speakers, which will be quick. And I would also like to mention here, for all the patient hearing, all the students, administrators, and also the esteemed delegates who have joined us from various government departments from the government, we will be giving away the participation certificate to them at the end of this summit at around 5:30. There will be a drop box outside. There will be a chit where you will be dropping your name, organization, and email ID. So end of the day, when you drop that sheet with your details, you will be sent a participation certificate with all these amazing government supporting this particular summit. That will be of a great value. So I would like to see all of you for active participation further till the end of this summit. So we would be starting off with yet another panel discussion. Over to you, Prerna.
I would request everybody to please take back your seats. All the students who are moving ahead, please get back to your seats. We have another short panel discussion of about 15 minutes, not much longer. I would request all our guest speakers and all the students and delegates to please take back your seats. We have a short panel discussion to conclude. Okay, moving on to our next panel discussion. The topic would be on healthcare leaders speak. And we would be discussing on value-based healthcare, service excellence through digitization, challenges in human resources in hospitals. We have 4 speakers for this panel discussion. Can I call upon Dr. B. Kishore Reddy, Managing Director and Ortho-Oncologist, Amor Hospitals, Hyderabad. Further, I would like to call upon Shri Saurabh Gupta, Regional Chief Operating Officer, KIMS Sunshine Hospitals, Telangana. I would like to call upon Ms. Uma, PhD Director, Communications, Relations and Partnerships, Access Health International, New Delhi, India. And the 4th and the final panelist for this discussion, please help me call upon Shri Prabin Bardhan, CEO and Vice Chairman, CureTech Solutions and Care for You Healthcare Solutions, Telangana and Odisha. And the moderator for this session would be Shri Prabin Bardhan, CEO and Vice Chairman, who will be moderating the session for us. Can I get the cordless mics, please? I request all the delegates, students, speakers, everyone to please take your seats. We'll have the small panel discussion and then we'll further move on to next segments. Thank you.
Hello. Good afternoon, everybody. It's a pleasure to be here. We have very diversified panelists today. We have Mr. Saurabh Gupta. He is the Regional CEO of KIMS Sunshine Hospital. Then we have Dr. Kishore Reddy. He is the Director in Amal Hospital. And then we have Ms. Uma. She is the Director of Access Health. The topic that we are going to discuss is value-based services, and then service excellence through digitization, and then the challenges that we face today in terms of human resources. I think there is nothing that exists in isolation, because when we talk about value-based services, I think it's through service excellence and then through the human resources that actually come forward and ensure that there is a value addition to every customer, meeting the expectation, right? But before we get directly jumped into the topic, I would like to really understand each of the three panelists, what they typically do for the differentiation that they create in each of their position and the hospital they belong to. Starting with Mr. Saurabh Gupta.
Okay. So good afternoon, everyone. I understand that we are standing between you and lunch, but we'll try to keep it short. I am Saurabh Gupta. I am the Regional Chief Operating Officer at KIMS Sunshine. I've been into industry for almost 20 years, half of which has been with management consulting firms like PwC and McKinsey, and half of that has been commissioning and operating hospital. I was with Medanta, Fortis, and now I'm with KIMS, looking over the Sunshine cluster. Thank you.
Yeah, how about Dr. Kishore?
Hi, good afternoon everyone, and it's a pleasure to be here, and I would like to thank indiGlobal team for putting up such a great show and inviting all of you and the great dignitaries here. It's a pleasure to be here. I am Dr. Kishore B. Reddy. I am an orthopedic oncologist and orthopedic surgeon. So my journey started almost 15 years back in Hyderabad, coming back from Singapore, starting as a consultant, growing as a head of department, and then growing as a medical director, and then entrepreneur now. So it's been a long journey, and that's where I am. So what I can give my 2 cents here in this discussion is at a micro level, at a grassroots level, what happens, because we are totally connected into the grassroots level. Even though the discussion is on a bird's eye view, but that is where we come. Thank you.
Yeah, how about you, Ms. Uma?
I'm Dr. Uma Isola. I have worked in the healthcare arena across the changes of healthcare, which is for 36 years now. From single specialty, multi-specialty diagnostics, I moved finally into public health about 7-8 years ago. So from single people and taking care of them to communities and working closely with governments, the changes that have occurred in healthcare are fascinating. It is a privilege that I'm invited by the indiGlobal group to share my perspectives and some of my stories, to be a part of this conversation this afternoon. Grateful to the audience that was actually stepped back.
In today's world is very dynamic, and patient typically become impatient, right? In that different aspects, when the billing happens, from there to the transition to value-based services can happen.
So as you know that NHM has put 5 points which are major in value-based services. And the outcome of that journey is what supports the hospital to pay for the services to both the doctors and the staff. This comes from the digitization of having a feedback form which is integrated by the care pathways that have been set by both the external agency and the internal processes. That needs no explanation. What needs to be worried about is who fills that feedback form? Is it the patient? Is it the attendant? Is it the nurse? Is it a junior doctor? Is that going to determine what the doctor is going to get paid, or how it's going to be, dissected across, and how the hospital is going to view the outcomes? It's hard to predict these kind of things. But if you look at it, the smaller hospitals and boutique hospitals may have an easier chance of making sure that they can actually implement this. The largest hospitals, the big hospital chains, can do so because they can have additional support to make these things happen. What happens to those people that are actually paying out of pocket? What happens to those people that are actually looking to make sure that they get the best value for money? These are all questions that value-based services is beginning to ask, because so far a fee-for-service or a fixed process for procedures and payments used to be the outcomes and used to be, manageable. How are these questions going to change the way in which we are going to pay for our services? These are tough questions. They are being looked at and also trying to be implemented as part of value-based services. So two things that actually happen there, which are very important. One, the digitization. How many of those feedback service forms do actually get digitized? And the second thing that happens is, who in the human resource that didn't have a bad day will fill that feedback form properly? So I rest my case. Thank you.
Yeah. So Dr. Kishore, with the changing expectation, I mean every other day you see the expectation of the patients are increasing. Do you think this is really possible to, when there are a lot of cost pressure, right, to really, value-based services are possible, the outcome-centric, billing is possible?
So with what Madam has just spoken about is very true, but one needs to understand the fuel or the system whole runs on the monetary aspect. And that's the key there, So we're not talking about the cream of the hospitals, which are very, very set, or we are not talking about the below poverty line cases. We are talking about the whole chunk of the middle class and the healthcare delivered to the middle class. There, we don't call, or the gone or that is being in the second generation, second or third generation doctors in my family. We have seen a sea of shift from, patient coming and falling in the feet and telling that you are the God, you please do that, to the scenario today that patients actually Google everything about me, including my publications, including my, probably my family or, where I stay, etc. And in fact, to be very surprised, one of the patient actually Googled my nakshatram. Before I operated the patient's son, actually they na nakshatram kuda chusi na jatakam kuda chusaru. I mean, it's a little bit weird, but that's the amount of the progress what we are seeing, or the demands from the patient. You can imagine what kind of demands the patients desire from us. So in that, to have certain standardization, okay. So here Kishore Reddy is there, he's doing a certain set of work, but as Madam was pointing out, when you look at a bigger systems, like it's very easy for me to run a place where I'm only working and have a group of say 100 employees or 150 employees where the quality control is very good. But when you're talking about like where Saurabh is working, like, it's a big broad spectrum. There you need to have standardization. Once this standardization comes, that is where the value additions or value creation or the expectations of the patient to be reached by a broad spectrum of healthcare professionals come in place, for which the feedback what is to be taken from the patients, whether it is data from the patient, whether it is healthcare record, or whether it is a complaint, everything should be very, very unbiased and neutral. Then only being in the top management, we can do some strategic changes so as to toggle with the system so that the healthcare system is better delivered.
So, Mr. Saurabh, what do you think is the impact of the TPA or insurance companies in terms of value-added services? What role do they play?
Okay, so before I actually get into this question, I would like to just touch upon what Ma'am and Dr. Kishore said. So it is important to understand who is taking the feedback in a hospital, but it is also important to understand at what point of time the feedback is taken. There are credible research which actually show that the patient or the attendant, when they are in the hospital, they are not in the right set of mind, or they are under pressure not to say not so good things about the management or the treatment or anything else. So many hospitals, including ours, they have resorted to actually taking the feedback after the patient gets discharged, say 2 days. And to hire, for getting it into a totally unbiased, to hire an additional agency, third party, who does our analysis. And that is the need of the hour, because that is where exactly the rubber hits the road. You exactly get to know what was the feedback of the patient, and then we have a weekly HOD meeting and we discuss it, whatever we can implement to that. So that's just my addition to the question. So gradually, we are around 30% of the payments throughout India are driven by insurance, whether it's any sort of insurance, employer-driven or private voluntary. And with the advent of Ayushman Bharat and other schemes, slowly the market is becoming, a payers market. So there are good things and bad things which we have seen from the West. Good thing is, as we are talking about the value-based care, there will be clear demarcations what will be reimbursed by the payer and what will not be reimbursed by the payer, which is good because you will not have malpractices. It will curtail the malpractice to some extent. However, this is healthcare. This is science as well as art. 2 + 2 may not be 4. So there are instances in hospital where you will have not so good results. And the problem is in our margins, and when I say our, the hospital industry margins are not as good as other industries, because ultimately it boils down to the same thing. We have investor money, we have to show the margins and impact. So what will happen? The treatment cost will actually have to be borne by the hospital, which will ultimately impact the P&L. So there are good things and bad things, but whatever we say, we are working or we are going towards the payer market where TP and insurance companies will actually control not only the payment but the choice of drugs and the choice of implants which we are using. The only thing is, if we can differentiate instead of using the same yardstick on the premium patient who can pay, he should be allowed to pay for the experimental therapy or a premium implant or premium device as compared to other people who can actually get equally good things, but they might not be so premium or the ostentation things. That's the only thing I would like to say.
So Dr. Kishore, so the doctors, they are the one who probably, at the highest of the pyramid. The question is, how do you actually percolate the service excellence to the next set of, staffs, right? Next set of workers within the organization?
So, I would very humbly disagree with you. We are not, as a doctor, we are not at the apex. Actually, the board is at the apex. Or someone who, or people like, Saurabh will be at the apex. Because they are the paymasters, So, yeah, probably we are, probably second or third line of defense before it comes there, All right, that's on a lighter note, okay. But yeah, so why I'm telling you this hierarchy in the healthcare system is that the idea of healthcare, why are we in a healthcare? I can only tell you one thing, that without passion, healthcare, no one can survive in healthcare. That much I can assure you. Because being in a healthcare profession, we forget our lives, we forget our personal life, we don't have timing. Our average lunchtime or dinner time is at least 2-3 hours more past the regular people. I envy my cousins and my family, my other families or my friends who are in good software professionals. They are doing excellent. Probably everyone have a sports car abroad, that's, but our thing is that passion. But what I can tell you is that if I do a proper job, and when I do a proper patient, and when they have a lot of gratitude towards you, and it's a lot of self-gratification. It's like by the end of the day, when you go and sleep, there'll be so much of peace of mind. It'll be contrary also. When you do something wrong, that amount of things also weigh with us. So what I'm trying to tell is that healthcare system, people can only sustain. They may take up healthcare, but the sustenance of healthcare is only when you have that passion in you and a fire in the belly that I want to do something good. Irrespective of the fact that we are literally underpaid. I can tell you that, healthcare as compared to any other profession, we are underpaid. And unfortunately, being in the care are two. One is it's a very capex-rich HR, or most of the OPEX is taken off by the HR. So if you tackle these two only, you can go to a certain extent of profitability. Ultimately, the people, either we put the money or some investors, they look at it as profitability. No one is there to do charity there. But ethically, if you have to do, we need to curtail these two, capex as well as OPEX, that is HR cost. Then only there will be some amount of profitability. Now there comes your question of how do we make sure that people are driven by this passion. So the people who are in the board or in the front line of the work, the first thing is that they need to be understanding, or there should be something called a human angle to everything what we do. That is something which has to come from top down, not from bottom up. So the whole, it should stop from the top management till down. If we are empathetic and we actually understand the pain of the patient, we'll make sure that even the housekeeping staff does that.
Right. I think, as they say, the patient satisfaction is not about the quality services provided by the doctor alone, because the first person that a patient interacts could probably is the security person, right? Unless they are really trained and also a party to the service excellence, I think the satisfaction would never happen. Mr. Saurabh, with the evolution of the technology, right, there are so many things that could be done in terms of building up the patient centricity. For example, your QMS, right? The waiting time typically is 2 hours for a patient in a busy hospital, right? Then there could be electronic medical record that, everybody wants to access the data, but unfortunately what has been observed is nobody wants to actually maintain the data. And then there are predictability that you can build. What is your thoughts on that?
So, this is actually a very good question and a bit controversial also. So, I would like to step back on what was happening pre-pandemic. So, healthcare, unfortunately, has been one of the laggards when it comes to adoption. Hospital providers are trying to build on service excellence. So that is the background. But what is happening in digital? So one thing is digital can actually impact in 2 ways. In fact, 3 ways. One is predictability. Second thing is repeatability. And third thing is convenience. So predictability. the QMS system which you are saying, or now you have AI-based QMS system which will actually tell you the wait time based on the past 10 or 15 consults. That will actually comfort the patient to let him know how much time he needs to wait before he goes for an ultrasound or an X-ray or to see a doctor. It will not reduce the wait time because there are very many variables, but at least it is predictable. You know how much time you'll have to wait. There are a lot of applications and nearly, every hospital is trying to do that. You have, I have seen some very good tracking systems in OT, because OT and ICU, they are called black boxes. You don't know what is happening to your patient, but I have seen some of the hospitals who are trying to actually tell, which is based on HMIS and other integration, what is happening to the patient, like patient is in pre-op or the surgery is going on, patient is out, which will again add to the predictability of the thing. And there are a lot of things which are coming. There are AI-based estimates which are available now. There is a hospital in Singapore which pioneered. Now Indian hospitals have also adopted. So this is just tip of the iceberg. The second thing is repeatability. Now this is very important because here is where your AI-based clinical decision systems come into place, which is more beneficial to the hospital operators, doctors, and it also enhances their productivity. Like we have gone for QAI, which is an AI-based algorithm to differentiate between a normal and abnormal X-ray. Medanta, which is my previous organization, did that 1.5 years back. So a lot of hospitals are doing that, and it also eases the life of a radiologist because he need not see all the X-rays. He has selected X-rays to look at. People are now trying that in CT scan and MRI. So this repeatability of thing is coming. And third thing, of course, is convenience. So it adds to the convenience of a patient to see things on app. You have AI-based chatbot. So this is what is happening right now. Now, I must also tell you one thing, which is, as I said, healthcare is a very late starter. I was in a AI summit around 10 days back in New Delhi, and I was fascinated with what is happening in other industries, not in healthcare. So when I asked the question, they said that, the requirement or the use case is not coming that much. As I said, we have been, trying digital to cut the cost instead of putting digital for patient convenience and staff convenience, including doctor. A lot of use cases because there are a lot of industries from which we can learn. Airline is one. So there are now, Noida International Airport, which is supposed to be the Asia's biggest airport. They gave a presentation on how they are planning to use AI. And I could have related so many things which we can do in our hospitals. So they are planning to have an app which will actually guide the patient through voice commands on the location of the gate. We can also do that, location of the OPD rooms. There are things like predictability of when he will be seen. Instead of calling names, an SMS or a WhatsApp message or an app message will come. So they are trying for several things. I am sure some of the hospitals will try and others will be compelled to do that. So there are so many use cases, and the future is limitless. We are just seeing tip of the iceberg. AI will transform the way healthcare is being delivered in the country, and of course it has already started happening. You are seeing unbundling of healthcare services. I was listening to one of the speakers in the previous session. They are saying, we cannot reach telemedicine. So telemedicine is a very good use case. We cannot reach the masses, and that's why telemedicine was used. But now there is a business case to use telemedicine. So in my previous organization, we were doing 90% of the follow-up calls because people were coming from far-flung areas, follow-up calls on telemedicine or video consult. So that is the use case, and there is a business case to it. Why not? It saves money, time, convenience, everything. So those are my thoughts on this.
So in continuation to that, as they say, earlier what used to happen is, patient comes, doctor treat, and it used to be very transactional. Now more and more patients are expecting there is a continuation of care, right? It is not only the time when they come for any specific need, it also beyond that point. If there is a surgery, there has to post-op stuff. There is an involvement that they expect from the hospital. So, ma'am, what do you think, how do we ensure that there is end-to-end care? And also, I would like you to highlight certain challenges that we face in terms of human resources. We all know there are attrition problem. In Hyderabad, typically, people first stop working and then give the, resignation. So in those kind of scenarios, how do you feel, we can take care of those?
Again, I come from a patient-centric approach. I was the country's first patient advocate at L.V. Prasad Institute, where we thought about the patient first. From the language he speaks to how he actually or she walks into the place, and how we can add a continuum of care, which means that every spot or every point that they touch base in the healthcare system is recognized as being one of the most important stops, and also taken forth with the seriousness of the patient being the person who is the most important. A lot of times you'll have the attendant who wants to state the problem, so you don't hear it from the patient. There are a lot of times when you don't know whether the patient really understood the prescription when they walked out, because somebody else is there to interpret it for them. So today you have language, you have AI, you have software, you have people, and the continuum of care is of course yet still dependent on the human resource element, which actually is one of the highest cost components, as has already been discussed by my previous panelists. How do you keep these people motivated to stay within your organization? Because a lot of time and money has both been spent on training, adapting them to a work culture that is unique to your organization, and also ensuring that they are in a position where they can both provide patient care and also look at the managed care aspects. 3 things that will come. Do you hire the right people for the right job? Today, there are hiring agencies that pick up the phone calls and talk. And they want to fill a slot because every slot filled means there's a remuneration to them. And they don't mind poaching people from my neighbor just to make sure that that slot is filled. And the person who's in that slot, who hasn't seen that 20% hike before, because healthcare hikes are difficult to give, is ready to jump for the smallest differential amount that they get. They forget that the organization that they leave is as important as the organization that they are going to, because they have most of their learnings from their previous organization. The second slot there is, how do you keep your people and how do you keep them motivated? The middle rung of the human resource is always the most abused. The patient screams at them, the doctor screams at them, the management screams at them. Management can't say much to the doctor. The patient cannot say much to the doctor or to the management. So that class of people who are the spine of the organization are often the people who receive it the most. And why would I want to receive it on an everyday basis? I'm the one who does extra hours at the end of the day because somebody didn't show up for a shift. Somebody walked out of the organization and sent their resignation in later. So that is a challenge that we continue to face. There used to be something called a June-July month we used to have in the past. I don't know if that still exists, where Dubai would open and recruit nurses. And it would mean that 50% of my nurses are going to go away. So I have to be able to make sure that I have my agencies lined up to recruit those nurses. At what cost? What is there? Every replacement is an additional cost. It is never at the same cost. It's cost plus. Plus, I'm going to bring in these people and start training them all over again. There's a cost of training. There's a cost of, ensuring that they understand your culture. So by the time you end up replacing one person, you have spent more than the cost of one or of two people. The third and the most important challenge is, how do you incentivize these people? And how do you actually make sure their appraisals are fair? Their managers are people who are right. People don't quit organizations. It's 300 rupees more or less. It's not going to change your life. But the mindset is, somebody got 7%, I got 5, somebody got 10. Kis basis pe diya, madam? And they'll walk into your office straight to ask you this question. Often, it is a subjective evaluation and not extremely objective. How are these people, those 300 rupees, going to change their lives? It's going to change their mindset. So, challenges in HR are always dynamic because they are people related. Each individual has a home, a family, an entire ecosystem, and a workplace that they come to. The day somebody leaves, 5 other people will be huddled up at the corner, at the water cooler or the coffee shop and say, "Chala gaya, usko to 20% zyada mil raha hai." And why am I not getting it? And that person who is going to leave will give you a little bit of a toxicity and say, "Yahan pe na," and give you one snide remark. You have to deal with that too. So the challenges of HR are as long as this conference. They are never ending. And I think all of us who are sitting here have such deep experience on the ground with the work that we do. We can set a whole day here. Forget your lunch. We can sit here till dinner to give you more and more examples of how these challenges need to be managed or how we have lived those stories through our lives. But yet, as hospital administrators, as doctors, as healthcare professionals, as IT professionals, as different levels of engagement in the public health system, each of us will stand every day to look for challenges that we are going to face and that we will have to make decisions right on that spot. So please ensure your decision-making skills, whether it is AI-based or it is just information, intuition, love, passion, whatever it is, are there to support the other person who has put in so many years of effort into becoming a healthcare professional. Healthcare profession is not like any other profession because it deals with human lives, life and death every day. And like I said, I could go on forever.
Thank you, ma'am. Yeah, I think you are right. I worked in at least 10-15 countries and all different parts of India. First time in Hyderabad, I saw that there is nothing called notice period. Yeah. So, anyway, if you want to ask any question to our panelists, please go ahead. So we have clarified all your doubts, right? So fantastic. So any closing comments before we just, close? Yeah, anything? Please go ahead.
Yeah. Hello. Hello, myself Vignesh Gaur Jewellery from Mallareddy Institute of Dental Sciences. Sir, as technology increases in medical field, but there is a disadvantage like unemployment and patient-doctor relationship will be affected, no sir? So how can it can be covered or managed, sir, if technology is introduced?
It's a really interesting question, I should say. See, before the industrial revolution, like in 40s, when the machinery came in, I mean, I'm not talking about even India, I'm talking about in the West. When the machines came, everyone were in panic telling that, okay, we are going to lose our jobs. Okay, so, but we have evolved. They are missionaries, but they are also people to run the machinery. So as we advance in technology, there will be a different sphere of works which will be created. And the dynamics or the perception of our business or our work will change. So yeah, so that's about your question, but I just wanted to add a couple of things about the AI, which is very, very pertinent, and it's the thing now, and which we should always look at for contributing a lot in the healthcare system, because it is at an abysmal level, I should call that as. So the AI, I feel that there are two challenges. Now, once you capture a data, you save it in a place, and that's in a cloud or whatever. It's called EMR, if you come to hospital industry. And it has to be, again, put it into an electronic health system. That is at a much more broader level, like at a community level or a government level. Then after that, this whole data should be compiled and analyzed, and it has to be going through some kind of data managing system, and then the AI comes in. So this is before the data, because now all the other industries where the AI is very, very strong is because they have a strong data which is captured and recorded. And unfortunately, in healthcare, especially in India, we don't have that mechanism, number one. Number two is that AI doesn't have emotions. And unfortunately, or fortunately, I should say fortunately, and for some reasons, unfortunately also, but healthcare is all about emotions. You know, if I go to a patient who is in growing in or in anguish and having a lot of pain, I can tell, how are you today? He's going to slap me on me. That's what is going to happen. Or I tell that out of 0 to 10.
So 3 quick comments. So just building on what Dr. Kishore said. So AI is not here to replace humans. AI will be a big complement. It is a complementary tool which we have to enhance our services, and you can see the scarcity of resources everywhere, especially in India, with respect to the healthcare workers. So AI and digital as a tool to enhance the patient experience, and also to protect our staff and enhance their experience, to reduce their workload, instead of just looking at it as a cost-cutting tool, which has been there for some time, which is actually a wrong approach. And if we take the first approach, it will actually be a good business model, because ultimately it is all about emotion, it is all about the word of mouth still, and it always will be in healthcare. And the third thing is on the data. Now, data collection is important, but the right format is also important. Data is the oil and crude oil. You must be knowing what is happening. India exported much more, in fact 8 to 10 times of refined petroleum products than it can actually produce crude oil. But the value of the refined products were much higher, because we got crude oil from everywhere. We have better refining capabilities, and that also goes with data. The one example is the capturing of data is it's actually very bad in hospitals. Some of the things like PIN code. The PIN code itself is such a beautiful indicator. You can do so many analytics on the PIN code and the place where patient is coming from. But I've seen 80% of hospitals, that is not a mandatory field. So you skip PIN code, you put any data, and when you try to filter the data, do analytics, it is all garbage in, garbage out. So it is very important to understand what are the 3-4 non-negotiable parameters of format which I need to maintain in a hospital.
I'm going to say my closing remarks.
Simple direct question. How do we increase the profitability industry?
Yeah, probably I'm not the right person to ask. He is the right person to ask, because and from my limited experience, I'll tell that don't start a hospital.
No, you told all of very, very facts. Because unless you have passion, you cannot come here.
I think CEOs and CEO are the ones who will better person to
So
answer.
there is no cookie cutter approach, ma'am. That's first. It is all situation based, but again, it flows from the passion and your high. So there will always be a niche in your doctors, in your technology, in your infrastructure location. The requirement is to actually identify the niche and sell it to the market. At the end of the day, now it is all customer driven. You call it patient, some people call it, there is always a debate, but ultimately patients are very much empowered. So if you identify the niche and sell that, because now it has changed from previously we were talking about SWOT analysis. It is more important to work on your strengths rather than your weaknesses. Because one incremental strength, one incremental step on your strength will actually multiply the benefits. Instead of working on your weaknesses, because weaknesses will take a lot of time. But you need to identify the strengths and work on that. That is the generic gyan I can give. But there are like a lot of things when it comes to profitability.
Thank you.
I have a very simple answer to this, and I have run businesses as much as I'm doing public health. A rupee saved is a rupee earned. Don't forget to look at your expenses as closely as you look at your earnings. Plug all those loopholes where you actually don't need to spend. Review every line item which has a certain impact on your profitability. This itself should bring up your profitability by a few percent. Very simple.
Thank you, Saurav, Dr. Kishore and Ms. Uma. I think it has been a wonderful session. My closing comments, because most of you are students, right? You have a question? Yeah, just before that, I just wanted to say two things to the students. One, I think most importantly, we have been talking about employment. So I think it's extremely important that we actually work on the employability. So build your skill. It's a continuous journey. Focus on how you can continuously develop your skill. The second thing that I wanted to leave behind is, be a good employee. See, all these people have been talking about how attritions and the aspirations of people, just 5,000 extra salary people are moving around. See, what is extremely important is when we talk about career, I think it's also extremely important that you learn, deliver and sustain. Yeah, make sure that you are a good employee.
Hello, sir. A simple question I want to ask. I'm
This
Dr.
is the
Mayura,
last
sir.
question we'll
Yeah,
take.
Dr. Mayura, sir. I just want to ask that how is AI used in real life? How is AI used in real life?
Anybody wants to?
In the healthcare you are asking or in general? Yeah, because
How it
you
is
watch,
used? I just
if
want
you have
to
a
know.
digital watch, right? That's a AI implementation, right? So all the data, all that you do every day, in and out, is the data which actually is an input to the predictability that is built for the future predictability, right? Yeah. So even for example, QMS system, right? The waiting time reduction. You can always implement AI. See, there are so many things. I actually come from, the technical background. So I can probably speak a lot on the AI part. See, what happens is doctor has a habit, right? So they come, treat, and during a particular duration of time, they actually treat as many patients with their waiting time,
How
approximately.
India is beneficial, sir?
Sorry?
How India is beneficial with this AI?
How?
India is beneficial with this AI, sir?
India, okay.
India is
How
beneficial or
see, India as a whole, obviously, I mean, individuals, I can tell you, and India as a whole is a collection of the people, right? So if you and me are getting benefits, that means it is translating to India is getting benefits.
What
right?
sort of challenge?
And there are so many large systems that is built on AI, right, which has been used by India. Even for, as a matter of fact, anything that is happening on the satellite, launch, or for that matter, protection of the country and all that. There are a lot of AI, implementation.
So I would like to just end by telling this. If we delay further lunch now, I think Sudhir and Mahesh should get IV fluids rather than lunch here. So I think we can catch up and we can discuss over the lunch. Yeah. Thank you.
Thank you.
So
Absolutely.
we'll talk more. Thank you very much.
Thank you. Thank you so much for this insightful session. Can I call upon Dr. Anuradha Medoju, Senior Regional Director, Telangana and Andhra Pradesh, Ministry of Health and Family Welfare, Government of India, to please come onto the dais so that we can give away the token of appreciation to our esteemed panelists here. Can I call forward Ms. Uma, PhD Director, Communications, Relations and Partnership, Axis Health International, New Delhi, India. Can I call upon Dr. B. Kishore Reddy, Managing Director and Ortho-Oncologist, Amar Hospitals, Hyderabad. Can I call upon Shri Saurabh Gupta, Regional Chief Operating Officer, King's Sunshine Hospital, Telangana. And finally, for moderating the session so well, can I call upon Shri Pravin Bardhan, CEO and Vice Chairman, CureTech Solutions and Care for You Healthcare Solutions, Telangana and Orissa. Request all the panelists to move forward for a group picture. And by the time the group picture is taken, we break for lunch now for about half an hour. And then we join back in the hall. So request everyone to please strictly stick to the deadline, that is half an hour. Please have lunch within half an hour and join us back in the hall. We have another last two panel discussions, and then we have the awards ceremony as well. And we have a box set up outside. So everyone please write in your names and your email IDs. And
everyone request the drop box will be placed after the last session of the summit. Then you can drop the chit that's been given to you with your details of email ID's name. Then it will be placed after the last session of the summit. Not now, last session. Thank you.
Hyderabad. Further, I would like to call Dr. S.S. Yadav, Chairman IMA's Hospital Board of India, Telangana State. I would like Dr. G. Swarnalata, in charge Jeevan Dhan program, to please join us on the dais. Further, I would like to call upon Professor Renu John, Co-founder and Head, Center for HealthCare, Entrepreneurship Professor, Biomedical Engineer, IIT Hyderabad. And finally, to join the panel, I would like to call upon Dr. Martha Ramesh, Liaison Officer, NIMS, and Associate of Hospital Administration. The panel discussion to begin, I request all the delegates to please move forward to occupy the forward seats so that we can begin with our session. Can I get the cordless mics, please? Over to you.
So, good afternoon all of you. I welcome you all again for the post-lunch session. Here, today's topic is the evolving landscape healthcare in Telangana. If you see the sea of changes in healthcare system in Telangana for the past 1 decade, and that leapfrog in infrastructure, that is in buildings, beds,
medical colleges and equipments. If you see, I am from the Tertiary Care Hospital, Gandhi Hospital. I am superintendent of Gandhi Hospital. If I talk about Gandhi Hospital, previously in Gandhi Hospital, there used to be 218 oxygen beds. But now, we are having 1900 oxygen beds. Among that, 700 are the ICU beds. So, we are having everything. So, in this, I would like to take the opinion of Dr. B. Nagender. He is a superintendent, Usmania General Hospital. Sir, how do you feel like the leapfrog in Usmania and this Tertiary Care Hospital?
Actually, the public health concerned with primary health care at the public primary health centers, and the secondary level is at a commissionerate hospital. Tertiary case is Usmania and Gandhi Hospital. You know very well that after 2014, a lot of developments are being taken up. And regarding the public health aspect, there is a Kanti Velugu program, which is preventable, avoidable blindness. To avoid the blindness, they have done a Kanti Velugu program, which is a flagship of Telangana government, which was successfully run, and lot of good results are come up. Another public health program, which is the flagship of Telangana, is a KCR kit, which will give 16 items to the pregnant mother. That is helped us decreasing the infant mortality rate, as well as improving the nutritional status of the pregnant mothers. Third is to help them in institutional delivery. You know, the institutional delivery will prevent the infant and maternal and infant mortality rate. So our Telangana government, after the 2014, our Telangana government stand third in reducing the infant mortality rate. After Kerala and Tamil Nadu, Telangana has become third place in decreasing the infant mortality rate and maternal mortality rate. Not only that, regarding the diagnostic centers, previously Telangana, anywhere public used to go to the visit to the tertiary care hospital for the high-end diagnostic blood tests and all these things. Telangana diagnostic centers are established. Around 134 blood tests are done at their place only. So this is a lot of improvement in public health sector, as well as recently our government has introduced a nutritional kit. So many of them are the problems with maternity mortality disease due to the malnutrition and iron deficiency anemia. So nutritional kit is distributed to the pregnant mothers so that their nutrition will be maintained. So from the starting of the care to give the best health sector, best health care for the sectors. And not only that, and regarding these medical colleges, so they have created more than 26 medical colleges till now on the basis of one medical college to each district. And again, yesterday there was a sanction of 8 more medical colleges. So 34 medical colleges, 33 districts. So that will give not only job opportunities like recruitment of the staff nurses, recruitment of the paramedical staff, as well as doctors. And our secondary, they will give the tertiary care at the district level, so that the load on the Usmania Gandhi Hospital, like tertiary care, will be decreased, and the patient will get a good treatment at their place. So, and regarding the beds, lot of improvement, thousands of bed strength is increased in the teaching hospital as well as commissionerate hospital. Equipment, particularly in Usmania Hospital, after the Telangana government, from the smallest equipment to large mega equipment like operating microscopes, laser surgeries, and MRI machine, CT scan machine, so on and so forth. We are able to give the tertiary care to the complex surgeries in our hospital, like liver transplants, kidney transplant. We have done around 751 kidney transplants in our Usmania hospital, and around 30 liver transplant and laser surgeries. And among the PPP model, we have done dialysis center. We have created dialysis center. More than 2,000 dialysis patients are being done under PPP model.
Thank you, sir. As sir told, actually, we are reducing the maternal mortality and infant mortality rate. So if you see the NICU, neonatal intensive care units, and the PICUs, and now MICUs, maternity intensive care units, they are more sophisticated and they are strengthened with so much of equipment and infrastructure. So it's a very good sign that decreasing the maternal mortality rate and infant mortality rate. Now, Dr. G. Swarnalata, she has done a lot of work in Jeevandan. So, ma'am, how do you see this? What's this leap? Like if I see this, NIMS is having a record in doing organ transplantations. How will you feel and how you see this?
So good afternoon. I thank the organizers for giving me the opportunity. So regarding the organ transplantation, so I'm proud to say that Telangana is #1 in terms of particularly deceased donor organ transplantation. And the program is called Jeevan. It's a flagship program of Government of Telangana. So across India, if you see, the organ donation rate is average is 0.8 per million population. But Telangana, it has crossed almost, I can say, around 5 to 10 times. It's 5.4 per million population. So it's one of the, I think it's a role model for the entire country. So the strength of our program, the Jeevandan program being, it is a government support, it's a government platform wherein we maintain a registry for all the patients who require organ transplantation, be it a liver, be it a kidney. So the centralized registry is being maintained. And Jeevandan is a regulatory authority run by the government, so it tries to, give the license to the hospital who want to enroll themselves for the organ transplantation. And whenever there is a potential donor, we try to, allocate these organs as per the guidelines to the recipients. The other strength of the program being the organ allocation is online. It's through a portal. I think it's unique in the entire country. None of the state have come up with such a sophisticated software to allocate the organs online, unbiased. So I think this is the strength of our government, and the other states, including 5 to 6 adjacent states, have tried to adopt our own software. It is unique, and then it has the first state to come up with such a model. So I think that's one of the greatest strength of our program. And the other, the most important thing is awareness, public awareness as well as the awareness amongst our own professionals. I think those two are the important, the key points to address so that we can actually, though I claim that this is being #1, in terms of the requirements, still we are lagging behind because there's a huge demand. As you can see, one of the important health problem in the entire the country, not only the country, as I can say the worldwide, it is the end-stage organ failure, the non-communicable diseases, which we are also talking about as a developing country. So we have a lot of patients who have this end-stage organ failure, and they are how do you look in future, particularly with respect to government hospital and private hospital? I think there is a huge what is called scope of improvement, though we stand #1. Because there's a lot of people, because all the
picture, what's going on in Telangana, this healthcare system.
Good evening, everyone. Three government officials speaking, and I was also a government official, although retired. Telangana definitely, from the time we have been working in the government sector to today, there are a lot of changes, a lot of good changes which have come. Things have become much better in the sense that patient treatment is happening in a proper way, and a lot of IT industry is coming into play so that things become more smoother. Earlier, the patient used to wait in a line to get a OP sheet done. All that has become computerized now. That way, it is all good. My question is not to the development. My question is to the small hospitals which are facing issues with Pollution Control Board regarding having STPs. STPs are sewage treatment plant for a small hospital. Nowadays, small hospitals are something, a house in the locality where a doctor goes, passes like you guys will pass tomorrow, start your own setup, and in a house you'll open a hospital, 15-bed, 20-bed hospital. And then the Pollution Control Board people say that you must have a sewage treatment plant costing around 5 lakh rupees. The income as such is just to start, and every bed is being charged for collecting the material, which is the things which come out from the patient, the dressing material and everything. Even after surgery, your organs which are there have to be sent to the PCB for collection and all. These problems are there more in the small setups. These problems have to be solved, including the fire thing. Old hospital, now the fire engine has to run all through the corners of the building. So these are the problems being faced by small nursing homes. Whatever said and done, healthcare, a very neglected thing in the past, now it is becoming better, all said and done. Still, 80% of the treatment is done by private hospitals. There is no doubt about that. It is not that the government hospitals are not doing that. They have their own burden, they have their own issues. A lot of poor people are going, but still there are some issues wherein the healthcare is set up, and even license to be taken to get a permission to start in a hospital have become a headache for the new doctors to come. I request the Government of India to look into these issues because the rules are coming from Government of India, PCB and the fire setup and all. Earlier nobody used to bother. And the most important thing, quackery. One good thing, many medical colleges, I think that indirectly will eradicate quackery to some extent because there will be a lot of doctors. Earlier people used to say that doctors are not available in mandals and taluks. Nowadays, even in small villages, MBBS doctor is there. So that issue must not be brought up once again. That issue is not the question. Regarding Madam's thing, I am also a member of IMA, National Board for Organ Donation. I think I'll discuss with you in a long term. Organ donation and people knowing when to give the organ and trying to report the matter so that many people's life can be saved. We only know of corneal transplant. That is one thing which is very common now. But the other organs, I am very happy that even in Usmania, Gandhi and NIMS, a lot of organ transplantation is happening. This is saving a lot of lives. I think we need still many more steps to go up. Although the steps taken are very good, but still downtown, people at the ground level are not getting the proper requirement. Maybe in a decade tomorrow, things will be much better. I hope healthcare industry in Telangana will become number 1 instead of 2 and 3 like it is presently. Thank you.
Yes, sir. The way how we are going, definitely at some point of the time will become number 1. And as you said, to start a nursing home, yes, registration and PCB and fire, everything should be there, sir. This is for the safety of the people and even for the patients. But the only thing is, as you said, probably there are some problems where we have to address them. And now we are having Professor Renu John. Sir is a professor, biomedical engineer, IIT Hyderabad. Sir, what's your views as a IITian?
So good evening to all of you. So I am probably the only person in the entire community who is really odd coming from an engineering or a technology perspective. I think if you look at the Telangana state as a whole, so this is one of the states that has come up really great in terms of leading in technologies. In fact, Hyderabad and Telangana as a whole has been a pharma hub, one of the largest pharma hubs in the country. And it has been one of the largest IT hubs. So the first thing which, from a technology perspective, when we notice is that, this is one of the states, one of the clinical communities which I have seen who has been very fast in embracing technologies, embracing advances and innovation in technologies. So whenever, wherever we approach the clinicians, both from the government sector and the private sector, we got such an overwhelming response from the doctors and clinicians to adapt new technologies. So if you look at what the state has been doing for the innovation ecosystem in the country, so we can see that, say, T-Hub, for example, housing more than 1,000 startups or even at least 200 of those coming from the medical devices or healthcare. So there has been focused programs announced by the state on digital healthcare, electronic health and medical records, projects and startups involving artificial intelligence and machine learning aspects to get into the medical devices, medical data, and introduce intelligence into the system so that it can assist and augment the physicians and the healthcare in the country. So apart from that, if you look at, say, a bunch of academic institutes in the state, both in the life sciences, a large number of defense institutes in the state. I think this is probably one of the states which has the largest number of defense research institutes. And academic institutes and even IIT, triple IITs. All of them have a focus component on healthcare and medical technologies. So I think the entire ecosystem has contributed heavily in nurturing the healthcare startups, healthcare devices and technologies, and also accelerating these projects to a level where it can easily transition to the bedside for the hospitals. So if you look at the hospitals, we have seen that all of these hospitals have been involved heavily during the COVID time in providing public health and care to the patients. So I'm listening to the viewpoints from the clinicians. I think this is one of the states which provides the best ecosystem for medical devices and technologies to be adapted. Thank you. Yeah.
Thank you, sir. Thank you, really. Actually, before COVID, honestly telling, I don't know about this technical aspects of this, like how you people are helping us and what is this biomedical engineers, what they will do. Really, we don't know. But the COVID has opened our eyes. And thank you, sir. We are having so many medical devices, and your inputs and your help definitely will take the medical into the heights. And now we are having Dr. Ramesh, who is the licensing officer of NIMS. Sir, how you feel? What Telangana government and health system need your comments?
Good evening, everyone. See, but today everybody is talking about the Telangana government healthcare industry journey. So I can tell you, so 2014 before and 2014 after, once Telangana formed. See, in that topic, beds, very recently, we have a dynamic, energetic, and a great leader. Very recently, you have seen in the Dashabdi celebrations on June 14th, and our Honorable CM has laid down the Bhumi Puja for 2,000 beds. Way back, the Nizam Nawab, he had given 23 acres of land donated. But whereas today's our Honorable CM, he had given 33 acres of the land. Just see the committing place in our Telangana. It's a vaccination hub, it's a pharma hub, we have wonderful tea hub. We are speakers, they spoke, but everything now, because we are using the technology like anything. But Hyderabad, especially in Telangana, Hyderabad is the healthcare hub. And thanks to our beloved director, Dr. Birappa sir, just 3 days back, 33 crores of worth. Come on guys, what else you want? So that is the journey of Telangana government and Telangana CM's vision and our Honorable Health Minister vision. And not only that, and just now our Raja Rao sir told, and our Usmania Superintendent Dr. Nagendra sir also told, there are 34 medical colleges in our state. Just see the amount of the healthcare development and what is the importance of the government is giving a lot of importance to the healthcare industry. But when my being a liaison officer at NIMS Hospital, 2014, our sir also is here. The planning budget, earlier government as a non-planning budget in few crores, just 20 crores or 13 crores. But only Honorable CM, he had exclusively had given 153 crores of rupees. Guys, so that's a huge 153 crores. He had sanctioned towards the equipment. Apart from that, and now you see, now we are thankful to the government, and we are the one of the Arogyasri patients now, even Usmania, Gandhi, and NIMS, these are all the government sectors. These are the government corporate hospitals of Telangana. That's the way they have improved, they have developed, and everybody is so much happy, and the faculty and the paramedicals. And apart from that, now in our NIMS, we have created that's allied health sciences, because apart from that, not only the medical seats and not only the faculty, and we are side by side by our government is giving a lot of helping hand to the allied sciences also. And that is the way. You see, so many beds, and nearly our Honorable Health Minister said 50,000 beds are going to add very soon. That is the greatest and the greatest commitment from the government of Telangana. Now, in the coming future, we are going to lead the globe, not only in India. Definitely, the Telangana is going to be the #1 in the world in healthcare sector. Thank you. Thank you very much.
Thank you, Dr. Ramesh. Yes, definitely. We will become #1. And now, as Dr. Ramesh is telling, so many sophisticated surgeries like organ transplants, CIBG, open heart surgeries, including CIZ, PTCA, cochlear implants, they are doing free of cost in tertiary care hospitals. Dr. Nagendra, how you are feeling like being one of the biggest tertiary care hospitals? So many organ transplantations or trauma care, or even now fertility centers are also there in government sector. Even for the fertility, they are spending a lot outside. As our Dr. S.S. Yadav sir told, 75% is served by private hospitals and only 25% is serving by the government. Whatever, see, health system is health system. We are all working for the patient, and we are working for the poor patients. Dr. Nagendra, how do you feel like medicines-wise? For example, now IV immunoglobulins and so many factors and biologics, such a costly medicine, we are giving free of cost in tertiary care hospitals. How do you feel, Dr. Nagendra?
I'm happy to share that in our hospital, for hemophilia patients, we are giving regular factors. So it is costing around 6 crores for a year, free of cost. So they can come at any time. The hematologist will be there. Factors are given free of cost. I think all the hemophilia patients of Telangana state come to Usmania Hospital. It is a very happy thing. And second thing is knee joint replacement and hip joint replacement surgeries. Under Arogyasri Ayushman Bharat, we are doing free of cost all these things, which is costing more than 3 lakhs for one joint in outside. So it is in a corporate hospital, complex surgeries are being done at government setup. This is a new trend in Telangana after the Telangana formation. Many of the complex procedures are being done in Usmania Hospital. So I am very, very happy to the government as well as kidney transplantation. First kidney transplantation we have done in 1986. But till now, the patient is surviving. And after this Telangana formation, number of transplant surgeries are being done at Usmania Hospital. It is crossed more than 756 transplant surgeries per hospital. We are very happy and it is very useful to the poor patient. They are done it free of cost under the Arogyasri Ayushman Bharat scheme.
Thank you, Dr. Nagender. Dr. Nagender is like a student of Usmania Medical College, and now he is heading the Usmania Hospital. And I am the student of Gandhi Medical College, and I am heading now Gandhi Hospital. We know during our student days how the Gandhi Medical College or Gandhi Hospital, what are the facilities, and how the Usmania Hospital and what are the facilities. We were not even aware of that. From that situation, now in our hospitals, all these things are happening at free of cost. And now, like this organ transplantation, especially kidney program is going on. How do you feel this Arogyasri is helpful for organ transplantation? Dr. Swarnalata.
Thank you, sir, for the question. So there is a misconception in the public that, the organ transplantation is only for the rich. So let me tell you that government has supported even the poor people. So this Arogyasri is available for all the we had around 1,000 one liver, the heart and lungs. So overall it will be around 5 to 8 organs. So overall if you look at around 4,000 organ transplantations have been done in this program. Crores we have told about the robotic surgery, robot for the surgery. So we have 33 hospitals being registered under this program, and out of which 3 are the government hospitals. The NIMS hospital, the Usmania and Gandhi, all 3 hospitals are active in the organ transplantation program, the deceased donor organ transplantation program. And over the past...
Clinicians, we concentrate on patients only. Now you know the other part also. This medical devices in the clinical practice. So do you find any obstacles here in connecting these two? I need your comments in this perspective.
Thank you. I think the gaps between the engineering and technology and clinical community has been bridged, and it's right now it is all interdisciplinary nature. We do visit hospitals, we do listen to clinicians, and clinicians are also very interested in coming and to technology institutes to understand how technology works. And so I think these gaps are getting built very fast. So when we look at as one of the panelists have mentioned about, we are going to be one of the global hubs of healthcare. So that's where we really need to look at. So as a country, we sort of, our medical device import is about 80%. So from there, we have to look at how do we export medical devices for the globe. So how do we become a global player, and what are the gaps there? So of course, if you look at the state, we have this medical devices park being set up at Sultanpur, which is one of the leading steps, which as we said, pharma hub and IT hub, tomorrow to be a medical devices hub for the world. This is one of the major initiatives the state has taken. There is a long way to go because we need good manufacturing practice labs, we need good manufacturing facilities. We need good medical device testing laboratories and regulatory facilities so that we make devices for the world complying to the global regulatory requirements. So I think that is where one of the areas where we have to emphasize, both from the technology perspective as well as from the funding perspective. Thank you.
Nice, sir. Nice inputs. Now, S.S. Yadav, sir. Like, as you said, this private sector definitely is contributing 75% of its services. And what more you need? Or now the way how it's going on, are you satisfied? Or you want to give any other inputs? For example, like you pointed out regarding this, so many registrations to start a small nursing home. Like that, is there any other points you want to enlighten here?
Nowadays in this world, we are thinking of making things smoother. Smoother to the extent that whenever we are hungry, we are behind Zomato, Swiggy to get the food for us. Although we are not that developed to get a child without anything else, like a e-child coming up tomorrow. But there are things which could be simplified. I am talking in terms of small hospitals, not in terms of corporate hospitals or any other hospitals. I think a single window system to see that these hospitals get a permit as fast as possible. Number two, a system wherein they can be given loan without much interest. Only the interest will start once they start to earn the amount from them. And then less rules and regulations. Although safety is the most priority thing, that thing cannot be there. We already have in our criteria how to establish a small nursing home, what are the safety aspects of it, what are the essential things which are needed for that. All these write-ups are done. From the people who are running these small setups, they want an assurance. Nowadays, a lot of violence is happening in this country on medical professionals, not just the doctors, even the sisters, staff, everybody is being attacked. We are representing from the past 8 years to the Government of India to get a rule for us so that the preparators of violence who are soft targets, they will not go to a revenue office, they will not go to electricity office, they will not go to another office to attack because they are more stronger. New doctors having a setup in a small place definitely need protection. Maybe the laws will help. Maybe the laws will make it more simple for them to see and do everything. Because ultimately, at the end of the day, medical science is not an exact science. That is why the role of AI is coming into play. We are trying to use artificial intelligence to see that we come to a good diagnosis and give good treatment. Indian doctors all over the world, the most respected people, the most respected doctors in the world are the Indians. We are experts in UK, USA, Europe, wherever you go, people think of going to an Indian doctor to get treated. Why? Because we are plain-hearted, we do a lot of hard work. As somebody said, we have a lot of compassion, and doctors who are people who come into the medical field are not come to earn, they have come to serve. Ultimate aim is the government must use us to serve the people instead of being otherwise. Thank you.
Right. Dr. Ramesh, first of all, I congratulate you because NIMS is going to be a 4,000 bed hospital. I think it's going to be a very big hospital in India, right? So I'm congratulating that. And what's your last closing remark? Want to have some closing remarks from you.
Sir, this is not my own statement. Recently, our Honorable Director, sir, had received the need to, from last 5 years patents, sir. My dear panelists, yeah, sir, Rajara, sir. Very recently, sir, our beloved director, Dr. Birappa, sir, had received the statement from the NEET. All the top rankers from Kashmir to Kanyakumari, they are choosing Nizam's Institute of Medical Sciences. This is not my word, sir. This is the NEET statement who had come from to our director, sir. Just think, sir, how the Telangana healthcare industry is growing on, and what is that? No, big, trust on one of the public sector gained. So the another fact, sir, I would like to conclude, sir, because you see, then Rajarao sir told, and Nagendra sir also told, sir, and our sir, we NIMS also receive 80% of the patients are from the Arogyasri. But sir, for them also, we are going to give a state-of-art equipment diagnostic facilities, and as well as, sir, very recently, we have purchased the robotic system. Apart from that, sir, we have wonderful PET scan and MRI and everything. So the most advanced state-of-art equipment our government has provided, and at this juncture and from this dais, I thank all that credit goes to our great leader, Honorable CM KCR sir, and Health Minister sir, Harish Rao sir, and thank you one and all, and thank you very much. Thank you, sir.
Thank you, sir. Madam. So ultimately, what's the closing remarks of you as far as the Jeevan Dan program is concerned?
As far as organ donation is concerned, I would like to just conclude saying that everybody can be a part of this program. You don't have to be a surgeon, you don't have to be a bureaucrat, you don't have to be a policy maker. Every common man or individual can be a part of this program by merely just pledging the organs. I think I have distributed all the forms for organ pledging. So please go through. There's nothing legal here. So nothing that we are going to take your organs. It's just a means of awareness. Pledge your organs. If you're not okay with pledging your organs, but okay, it's fine. You please, pass on the message to your own friends, family members, or get awareness in the public so that we don't find people dying of lack of organs. Thank you. Thank you very much.
Sir, Professor Renu John, your closing remarks on technological perspective.
So let's take up the vision of the state in building a good ecosystem, supporting the healthcare, and one of the best states in the country, and show a model to the globe. Thank you.
So I thank all the panelists for participating in this session. Any question and answers? Yeah. Sir is telling healthcare is doing well, that's why no questions here. If no questions, we'll close the sessions and we can discuss over the tea. Thank you all.
Thanks to all the moderator and the panelists for having such an wonderful and insightful session. I would like you all to take your seats because I would now I would like to call upon Dr. Shafqat Khan, Additional Mission Director, AB Digital Health Mission, Jammu and Kashmir, to please come on to the dais to give away the mementos to our panelists here. I would like Dr. M. Raja Rao, Superintendent, Gandhi Hospital, Hyderabad, to please come ahead and receive the memento for moderating the session so well. Next, I would like to call upon Dr. B. Nagendra, Superintendent, Osmania General Hospital, Hyderabad. I would request Dr. S.S. Yadav, Chairman, IMA's Hospital Board of India, Telangana State, to please come and take the token of appreciation. I would request Dr. G. Swarnalata, in charge Jeevan Dhan program, to please accept a small token of appreciation. Further, I would like Professor Renu John, co-founder and head, Center for Healthcare Entrepreneurship, Professor Biomedical Engineering, IIT Hyderabad, to please take a small token of appreciation. The final panelist for the evening, Dr. Martha Ramesh, Liaison Officer NIMS and President of AHA. I would request all the panelists to please come forward for a group picture. And now everybody, repeating once again, we are live on Facebook and YouTube. Request every one of you all to please subscribe, share, and let your friends, colleagues, and relatives know that you are attending the Healthcare Summit. Moving ahead, thanks to all the panelists. Moving ahead for the next segment, we have our indiGlobal Awards ceremony being held now. We'll be having it within the next 5 minutes. I hope everyone brace yourself. This is the last segment for the evening. Post this, we will have an high tea and end with that, and then you all can network and visit the expo. For now, we will be having the award ceremony. Anyone who is outside, delegates, speakers, request every one of you all to please move back into the hall so that we can begin with our session. Request the team to please make arrangements to start with the award ceremony.
A very good evening to all of you. Music, apart from being a great entertaining platform, has got to profound benefits on the mind and body. Music travels from the source via the sound waves, and as soon as it reaches the mind of the listener or the brain sends signals to different parts of the body. And as we graduate or evolve from hearing to listening, our body starts producing the feel-good hormone called endorphins. And this is the worried about cardiac health, about our heart, about our liver, about our stomach, about our gut. But seldom do we think that our brain also has got may get degenerated, may need help, may need medication, may need counseling, may need tender loving care. Hence, to break the myth of mental health is extremely important before we start on the journey or embark on a journey of skilling and preparing our youth for Amrit Kal for the next 25 years. And some of the most powerful mediums of mental health can be music, art, dance, literature. The fine arts are called fine not to be for the classes, are called fine because they are really very, very soft and soothing on the senses. The violin is supposedly a Western instrument, but it can play all kinds of music. And why are we calling this session Creativity and Well-Being Through Music? They were doing the bihu with me, but that was, yes, I've never done a workshop anywhere in my life where the audience hasn't clapped after the first song. So, thank you for making it worthwhile. Well, this was a beautiful song composed with a lot of thought. What about a song in a cabaret? Will that have 7 notes? Sampa, tani sani da sampa, tani sani da pa re, re ga ma pa re, ga ma pa ma ga pa re, ga ma ga pa ga re sa. Sa sa ni sa re ga re, sa ni sa pa. गाना बोलने से नहीं होता है, गाना गाने से होता है. Far across the distance and the spaces between us. So these students nahi hai bhai. So sad. But we have some people here. Sa 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 ni sa pa, sa re sa pa ma ga re ga ma ga re sa re sa. My heart will go on and on. Sa re ga re sa re pa ga pa ga re tha re sa re da pa ga sa sa ni sa re ga re sa. I haven't been trained in Western music. My son is a Western pianist. I have never been trained, but I have been trained in one domain of Indian classical music. So the deeper the depth, the wider the expertise. I'm not saying I'm a great singer or a great violinist, but training in one discipline in depth. When I asked my mother, when can I stop playing this rag Bilawal? So boring to play the same rag. She said, you do not stop playing a rag. You keep developing it, discovering it, trying it out over and over again, and you discover various facets of the same rag. Hence, they say, deeper the depth, wider the expertise. And what do businesses want today? We want to create more with less. We have the same talent. We want to skill ourselves further to deliver more for the world. Hence, music, the 7 notes, the way we create them across genres, only 7 notes, but hundreds and thousands and millions and trillions of melodies are being created with the 7 notes, because there is a structure that we follow. There is a theory that we have studied. There is an SOP, a standard operating procedure, every time we do a musical setup. And music is as much a science as much as it's an art. Hence, it's used for creativity. And creativity enhances our brain cells, creates better cognitive preservation. On that note, I'd like to end this section with a highlight piece. It's a Mozart. क्या हमने Mozart सीखा है? बिल्कुल नहीं. I have learned violin from my mother, who taught me only Indian classical music. No matter what language we speak, which part of the world, village we are from, we don't have to be in the Ivy League to do well in life. We need to have the intent to learn, to communicate, and to represent our skills in the best insightful way that we can. Only then can the skill initiative be successful, when students have got calm and composed minds, good mental health, a sense of wanting to learn, and a need to express themselves to the world and to the need of the hour. So Mozart with the same rag Bilawal. Let me see if you can guess this piece. Sa ni sa re sa re ga pa ma ga re sa ni sa re ga pa ma ga re sa ni da pa ma da pa ma ga re ma ga re sa ni sa re. That was Mozart. Well, that was the second thing about music that we discovered today. Everyone knows music is entertainment. We learned about music, therapy, and creativity. Well, this workshop is usually 2 hours old, 2 hours long. I'm trying to do it in 10 minutes. The third very profound lesson of music or the arts that we must imbibe with our students, youth, executives, leaders, board members, and rulers of nations, that art teaches us the best lesson of working together. The orchestra is the strongest metaphor to learn about leadership, working together, working for a larger goal, working with the small and big pieces together, working with differences, working with all kinds of languages. We have today leather, wind, because my keyboardist didn't arrive, so we have Jugen here. क्लैप बजाइए भाई, तब से साउंड चेक, आधा घंटा आपको साउंड चेक में सुनाया, तो क्लैप बजाइए. Dibbajyoti on the tabla. Music also teaches us innovation and adaptation. Because we had a short session, we used the table for the tabla. I didn't sit on the platform because we had to do it fast. So music teaches us, or the engagement of the orchestra teaches us lessons of working together, the art of partnerships. It's so nice to say, let's start a joint venture. I'm sure after this conference, so many of us will get together, so many entities will get together to start ventures, grow together. But jab tak art nahi hoga in the relationship.
Hello. Thank you for the patient waiting over here. I think that wait is worth worth waiting because we are going to recognize and felicitate those who have given years and decades of their hard work, their innovation for the services of people, for a better healthcare system in India in their respective fields. So we would be starting off with the indiGlobal Award ceremony. We'll be shortly joined by our special guest from the state of Punjab, Dr. Adapa Karthik, who is the Special Secretary for Health, Medical, Family Welfare, also for IT Department. And just to take you through the brief idea about this indiGlobal Award ceremony is unless there is a strong leadership to drive whatever the resource that is there with the government or with the central or state government, there is a strong leadership needed to drive so that we get the desired results. So there would be leadership awards given to those who have been on the ground, led the team, led the funding in the right direction, and ensured that there is a transformational change in the healthcare system for the benefit of citizens. So there will be Visionary Leadership Award, there would be Transformational Leadership Award, and at the same time there are certain initiatives of certain institutions and organizations that stand out as a best practice. And they have got some good results, be it in terms of integration of technology, or be it health insurance, be it state or central health insurance. And that is where it stands out from the rest of the initiatives in other states, so that there is something to learn from these initiatives. So we will be giving away this Excellence Award, Transformation Leadership Award, Visionary Leadership Award to some of the esteemed guests who have joined us, and their initiatives, their work have been nominated, and it has gone through a proper examination by a set of jury members who are basically the bureaucrats and who have been the leaders in the healthcare system. So these nominations have gone through the upfront nomination by the respective organization and nomination by some others who admire or look up to their work, and after various submissions of nominations, only few of the awards have been shortlisted. I think there is a number of 7 out of hundreds of awards that's been nominated for. So without further ado, we'll be joined by our guest from Punjab. I would like to call upon our special guest who represent the Ministry of Health and Family Welfare, Government of India, for the state of Telangana and Andhra Pradesh. Please join me in welcoming Dr. Anuradha Medoji. A round of applause, ma'am. Please join us so that we give over the awards to these people who have been, who have done some amazing work. And I would also like to call upon yet another dignitary who is a well-known name in the healthcare sector. He is the director for Nizam Institute of Medical Science. So please join me in welcoming Dr. Nagari Veerappa, Director for Nizam Institute of Medical Sciences, Hyderabad. So I would like to call upon Vishal to bring upon the awards that have been shortlisted. Let us bring that energy so that our awardees feel that energy and they give out more to the society. A round of applause for all the awardees here.
Good evening, everybody. Now we start off with our first award. And this award is in the category of Outstanding Initiative in Implementing category. Technology goes to SAS Analytics for its collaborating with the government of Odisha for creating a COVID-19 dashboard that resulted in tracking cases, allocating medical resources, and prepare for future crises. The technology intervention helped the government create positive impact, enhance efficiency, and help tackle medical emergencies and stay ahead in the war against the pandemic. So give a huge round of applause for this. Yes.
I would like to call upon Dr. Karthik onto the stage to give away the awards.
Can we cheer for the winners? Ladies and gentlemen, here are the winner for the Outstanding Initiative in Implementing Technology.
That's the SAS Analytics. Congratulations, SAS Analytics team. Moving to our next awardee, that is in the category of Outstanding Initiative in Healthcare Delivery. Can we please call upon Dr. Ratan U. Kelkar, IAS. On behalf of Dr. Ratan, I think we have Dr. Bijoy who will be joining us. And this award is being given to Dr. Ratan of Kerala for fostering collaboration, embracing technology and implementing patient-centered models and providing leadership in the implementation of Arogya Kiranam scheme in Kerala. Their groundbreaking initiatives and forward-thinking strategies have set new benchmark for excellence in healthcare delivery. Congratulations, Dr. Ratan, and jointly Dr. Bijoy.
The indiGlobal Outstanding Initiative in Healthcare Delivery Award is presented to Dr. Shafkat Khan, Additional Mission Director, Ayushman Bharat Digital Mission, Jammu and Kashmir, for the speedy implementation of Ayushman Bharat Digital Mission and achieving third slot across the country within a short span of 2 months of starting scan and share facility. The forward-thinking strategies have set new benchmarks for excellence in healthcare delivery. Ladies and gentlemen, let's give a huge round of applause for such a great achievement.
Moving to the next category, the indiGlobal Excellence Award is being given to Dr. Sudha Chandrasekhar for technical assistance, consultancy and implementation of various health schemes in regional as well as national level. As a health economist, your outstanding contributions and achievements in research, leadership and significant impact have not only advanced the understanding of healthcare economics, but also improved the lives of countless individuals. Congratulations, Dr. Sudha.
Now the next award for the category of Excellence Award for the Leadership goes to Dr. G. Swarnalata, Senior Medical Professional and in charge of Jeevandan Nizam's Institute of Medical Sciences, Hyderabad, for leading the Jeevandan program and improved organ transplantations outcomes and facilitating a new lease to countless lives. I think it deserves a huge round of applause, ladies and gentlemen. It's one of the benchmarks. Can we hear a huge round of applause?
Moving to our next category, the indiGlobal Exemplary Service Award is being presented to Ms. Tejawat Sushila for her untiring and consistent service rendered in Gotikoya, a tribal habitation. She has over 25 years of experience as auxiliary nurse midwife. She has demonstrated exceptional compassion, tireless dedication, especially during the pandemic. By her unwavering commitment to deliver high-quality care, she has become a beacon of hope and inspiration to all. Congratulations, Ms. Tejawat Sushila. Can we hear some applause for the achievers here, please?
Now this next award, I'm sure the audience who are sitting sitting here, they can connect with this awardee. Now, the Clinical Excellence in Public Health Award is presented to Gandhi Hospital for providing compassionate and patient-centered care, especially during the COVID-19. Thank you so much. Bye from indiGlobal Media Network. See you soon. Take care. Shabba khair.
And for everyone who need their pictures, their videos, everything will be uploaded on Facebook page on indiGlobal Media Network. You can go into the page, search for the page, and you can download your pictures or videos from there. Yeah, thank you. The indiGlobal team to please come onto the dais for a group picture.
I think please volunteers also please assemble this side. We shall take a picture to mark this moment.